Okay, we are live in 5, 4, 3, 2, and 1. Now, I hope my 2 and 1. I hope my screen is visible to all.
Yes, yes. Go ahead.
Okay. So, good afternoon, honorable respected faculties and
I hope my screen is visible to all.
on the behalf
Yes,
of
yes.
Corona Remedies,
Go ahead.
Corona Remedies
Okay.
Limited.
So,
I,
good afternoon, honorable
welcome you
respected
all
faculties
for
and
the
I
Core
hope my
Connect
screen
Live
is visible
webinar
to all.
on the behalf
Yes.
of
Corona Remedies.
ICOG.
Corona
Sorry to interrupt you, Soham. It's echoing. Your voice is echoing. You need
Okay.
to-
In association with Maharashtra
Sorry
Society.
to interrupt you, Soham. It's echoing.
Okay.
Your voice is echoing.
I would like to
in
introduce.
association with Maharashtra
Sorry
Society.
to interrupt you, Soham. It's echoing.
I think someone's voice is being.
I would like to
just a
introduce
second.
with Maharashtra
Sorry
Society.
to interrupt. No, there is some technical problem from your side, Soham.
Okay, I'll just see, ma'am. Just a second. Just give me a minute.
No, there is some technical problem from your side, Soham.
Okay, I'll just see, ma'am. Just a second. Just give me a minute.
No, there is some technical problem.
Devices he is.
Okay, I'll just see, ma'am. Just a second. Just give me a minute.
No, there is some technical
Two
problem.
devices he is.
Okay, I'll just see, ma'am. Okay, now it won't become. So I would like to introduce the. Am I audible, right? Okay, now it won't become.
Yes.
Yeah, so I would like to introduce the convener for the session. I would like to introduce Dr. Sneha Boyar, State Coordinator, AMOX, Founder President, Vidarbha, ISO PARB, ISOPAR. State Coordinator, AMOX, Founder President, Vidarbha.
Soham, audio is still defective.
Okay, just give me a minute.
It's keep on repeating.
Yeah, just I think my YouTube is also live.
Still defective.
That's why. Just give me a minute.
It's keep on repeating.
I think now it won't be coming. Is it repeating now?
No, go ahead.
Okay, ma'am, and so I would like to request Dr. Sneha to start the session.
Yes, so a very good evening to one and all. And at the outset, I welcome all of you here for this academic session, which is organized by ICOG. We are here to welcome especially Dr. Bhaskar Pal, President Foxy, who is busy in another program, Chairperson of ICOG, Dr. Sheila Mane, Dr. Amey Purandare, the President of AMOX, and Dr. Rajesh Modi, the past Vice President of Foxy and President of Akola Ops Gynae Society right now. So, friends, this is a program called as 7H. As all of you know that we are having a very high maternal mortality, though as a matter of fact, Maharashtra is way ahead in coming to the double number figure, almost second in number from all over country. The credit goes to you all obstetricians who are actually working on the ground. We are thankful to the Maharashtra Ops Gynae Society President, the past President, Dr. Kiran Kurtakoti, and Dr. Amey Purandare for taking so many initiatives which actually they are implementing at the grassroots level. So with this brief introduction, I would just welcome all the president secretaries of Akola Ops Gynae Society, Amravati Society, Devi Savangi and Sevagram Varda societies. I welcome all the respected seniors, dignitaries, the speakers, Dr. Pushpa Zungare, Somunshi Madam, who will be speaking on obesity and pregnancy, and Dr. Shuchi Jain will be, and also we have a very interesting panel on the medical disorders of pregnancy, especially the anemia, hypertension, hyperglycemia. We're very happy to have Professor Shuchi Jain because she'll be speaking on a very important yet neglected topic of HIV and pregnancy. So once again, I welcome all of you. and I welcome the respected dignitaries. Soham, you can share Dr. Bhaskar Pal's CV for a while, and because he's not here, maybe we can have him later. So all of you know Dr. Bhaskar Pal, who is the president of FOXI and doing so many activities simultaneously. So we're just looking forward to have him sometime later. We now welcome Madam Sheila Mane, who is also the chief guest and the brain behind this program. You can display Madam's CV, please. So she's the ICOG chairperson for the year 2026, member of Health System Strengthening Committee, HSSC FIGO, Vice President FOXI 2040, and I'm sure she is known as PPH lady. All of you are well aware. She's got lots of credentials and awards and accolades to her credit. May we have Madam Sheila Mane for her precious words. Over to you, Madam.
Good afternoon, everybody. And at the outset, I think I really feel privileged today to be there as a chief guest for this 7H CME. And I would like to thank all the president and secretaries of all the societies, that is Akola, Amravati, then I think Devli Sabangi, Varda, Sevagram, Pusad societies for participating in this CME. Now, why did I have named it as 7Hs because I have taken a module of hypertension, hyperglycemia, HB, that is anemia, then hemorrhage, as well as HIV/AIDS, then high BMI and hormones. And I felt that these 7 topics are very important, and I am very happy to know that Maharashtra is really marching forward, and we know that Maharashtra is second in the country now, where the MMR is reduced drastically. And I think it is a contribution by all. So the very important topics selected for this webinar by these societies are that is HIV/AIDS as well as high BMI. And I think the panel discussion is going to be again on a HIV, that is anemia in pregnancy, as well as hypothyroidism and hyperthyroidism and HIV. So most of the topics will get covered. And HIV/AIDS is equally important because to be very frank with you, I have attended the NACO workshop, and what we find out that the social fabric is really, I think, getting changed, I can say. And unless and until we really take care, because vertical transmission is in our hands. And nowadays we see many patients VDRL positive, which we had forgotten. So both these things will be covered, I think, in this PPT. So I'm really thankful to all of you for coming positively forwards, and it's nice to see the amalgamation of so many people. I know Madam Pushpa Zungare as a very senior person from Amravati and very well associated, as well as everybody, Suchi Jain, Nikita, all those who are going to I think talk as well as moderate the panel. So I welcome you all, and most important, Dr. Sneha Buyar. All of us, we know her leadership qualities, and the moment I tell her, the program gets ready. It's so easy to work with Sneha. So Sneha, thank you very much for coordinating this wonderful program. Thank you.
Thank you so much.
And also, I would like to thank Dr. Ameya, and Dr. Rajesh Modi for accepting to be there as a guest of honor. And Ameya being the AMOX president, it's really a proud moment for me to have you in this 7H CME.
Thank you so much, Madam. I welcome Dr. Amey Purandare, the President of Maharashtra Societies, AMOX, which we are very proud of and proud member of. All of you know Dr. Amey as a very revered academician and teacher par excellence. He is known for his ornamental language, I would say, and we are very eager to listen to you, Dr. Amey. All of us know what your credentials are, so we are really happy to have you as guest of honor, and over to you for your guidance.
Thank you, Dr. Sneha Buyar, for those kind words. It gives me a great sense of privilege and pride to be here this afternoon for this FOXI 7H ICOG CME. Indeed, it is under the leadership of our visionary president, Dr. Bhaskar Pal, and our extremely hardworking and dedicated ICOG chair, Dr. Sheila Mane, and the entire Foxy leadership and ICOG leadership who have taken the academics at Foxy at a very high level. So, congratulations to the ICOG for year on year raising the benchmark of academics, which is one of the key uh, objectives of Foxy. It gives me great pleasure to have Dr. Rajesh Modi as a co-guest of honor. Both of us are batchmates in our UG and PG, and it is a strange coincidence to be there together sharing the stage. My special thanks to Dr. Sneha Buyar, who is an essential and important part of my team in AMOX, and she is an excellent worker and a very dedicated OBGYN, not only in Maharashtra but all over the country. Also, the coordinators, Dr. Manisha Ghate and Dr. Pranjal Sharma, again, key members of my team AMOX this year and working very hard in Maharashtra. We are very happy to have eminent speakers. And what can I say about uh, uh, Somvanshi madam, Jungare madam, that she is one of our most respected teachers in Maharashtra. And in fact, when we have recently awarded her the AMOG's Valor Award, Shaurya Award, for the exemplary courage that she has shown in reducing maternal mortality in the state of Maharashtra. She will be talking to us about a very important topic which has become a menace today, not just in pregnancy, but before and after as well, and that is obesity. We have Dr. Suchi Jain, who is from Sevagram, the president of the Sevagram Society, who is going to talk about HIV positive pregnancy. And in my installation speech at AMOGS, I said AMOGS is initiating the change in mindset proposed by the WHO that U equals to U, undetected equals to untransmitted. The panel discussion is going to be moderated by Dr. Nikita and the experts like Dr. Sheila Mane, Dr. Sneha Buyar, and all the representatives from the key societies of AMOX from the Vidarbha region, namely Akola, Amravati, Devli Savangi, Wardha, Sevagram, Pusad, are going to be participating and giving insightful inputs in managing these very important high risk pregnancies. So, once again, it is my pleasure and privilege to be here this afternoon. I wish the CME a grand success. I'm sure that all those attending this ICOG CME will benefit greatly from the dissemination of knowledge by these eminent faculty, very well chosen by Team ICOG. So, happy learning, and let's pledge that the women of India, the Nari Shakti, will be really the Nari Swasthya for the future.
Thank you so much, Dr. Ameya. I'm sure all of us are charged up with your message, and we're sure that everybody will work for the cause. Thank you so much for your precious words. Dr. Rajesh Modi is held up in some operative procedure. I think the moment he joins, we will have his precious words. And I think let us now go ahead with the academic session. Let me just thank once again all the dignitaries, Dr. Bhaskar Pal, the President Foxy, Dr. Sheila Mane, the ICOG Chairperson, Dr. Amer Purandare, the President of AMOX, and Dr. Rajesh Modi as guest of honor. I thank my coordinators, dear friends, Dr. Pranjal Sharma and Dr. Manisha Ghate for being so, vibrant in organizing this program. And I thank all the faculties once again to accept our invitation. Thank you so much. And over to you, Dr. Pranjal. So all of you know Dr. Pranjal Sharma, the past president of Amravati Society. I'm so sorry, we have just skipped the invocation video. So Soham, I would like to, hello, Soham?
Yes, yes, ma'am.
Yeah, please play the invocation video. We definitely watch this. Thank you so much. And with the blessings of God Almighty and the blessings of respected seniors, we would like to go ahead with the academic session. And yes, we would like to hand over the session to Dr. Pranjal Sharma, Vice President of Amravati Society, and of course, the Zonal Coordinator, past Zonal Coordinator for Zone 6, and Dr.
Madam,
Manisha Gate, who
Thank you
is
so much. Thank you so much, madam.
the past President of Chandrapur. Over to you, Dr. Pranjal.
Thank you, Dr. Sneha, madam, for considering us for this task. I welcome, on behalf of ICOG, I again welcome you all, dignitaries, respected Sheila Mani, madam, Dr. Ameya Purandare, sir, again Sneha Buyar, madam, Dr. Somanshi, madam, and my all dear friends, Dr. Suchi, madam, and my dear friends. So let us move for the first section without much ado. I would like to invite our three chairpersons, Dr. Praveena Jain, Dr. Sneha Agarwal, and Dr. Meera Dange. Three distinguished personalities creating great impact in their fields. So, CV of Dr. Praveena Jain, please. Dr. Praveena Jain is a consultant of OBGYN. She is infertility specialist and endoscopic surgeon. She's MBBS DGO. She also had ICOG fellowship in ART as well as in gynec endoscopy. She has 10 plus years of experience in government, private and corporate sectors. She is consultant at Jain Hospitals and Shakuntal IVF Center, Varur. Uh, in She has a great academic contributions like case report of giant fast growing intramural leiomyoma, and she co-authored textbook chapter fluid management in hysteroscopy. She was past secretary SWOG 2021 and current joint secretary SWOGS. She is from Varda. We welcome you. We welcome you, Dr. Jain. Next CV.
Thank you so much, ma'am, for the kind words.
Thank you so much.
Next, CV, Soham.
We have another distinguished personality, Dr. Sneha Agarwal, who is MBBS DGO DFP DFCCS from Akola. She is a director of Vatsalya Women's Hospital. She's working as a consultant obstetrics and gynecologist, and she was joint secretary Akola OBGYN Society 2022 and 23. So welcome, Dr. Sneha. Dr. Meera Dange. Next CV, please.
Thank you so much, ma'am.
Thank you. Welcome. Dr. Meera Dange is the Secretary, Pusad OBGYN Society, 2627. She is a consultant obstetrician and director of Dange Maternity and ENT Nursing Home, Pusad. Practicing since 19 years, she is a life member of IMA Pusad, managing director of late Prabhakar Rao Dange Memorial Trust, Vidul. So with these three distinguished figures from their field, we can start first. So I hand over mic to Dr. Praveena Jain for introducing our most respected Dr. Somanshi, madam.
Can we have
Dr. Praveena Jain?
Yes, ma'am. Can we have the CV, please?
Yes.
Yeah, it's displayed.
So, yes, we welcome with all our heart Dr. Pushpa Junghare, madam.
Hello.
Am I audible?
Yes, you are audible.
Okay. Yes, so all of us know that she is a great obstetrician and gynecologist. She is professor and head of department OBGY PDMCC Amravati. She's a member of UG and PG Board of Studies of Surgery and Allied Subjects in MUHS and member of Faculty of Medicine in MUHS. She was first visiting professor sent by Foxy to Cuttack Medical College, Odisha, and she is also a PhD guide. She is a faculty in many national, state, and zonal conferences, CMEs, and workshops. She has been UG and PG examiner at various universities in India.
Dr. Praveena,
Yes, ma'am.
I think that should be enough. Thank you for the kind words.
Yes. I would like to welcome ma'am on behalf of all of us. Thank you, ma'am, for joining us.
Yeah, Soham, please stop sharing. Let Madam share her screen.
So my PPT is visible.
Yes, ma'am. Please get to full screen.
I am audible as well.
Yes, ma'am.
So first of all, I would like to thank Dr. Sheila Mane and Dr. Sneha. I feel privileged to be a part of this 7H program. And I think it is definitely going to benefit all the obstetricians and gynecologists fraternity across the country. So starting with this obesity problems during pregnancy, I think it may even pose problem right for conception. So I would like to label it as the problems of obesity right from conception till the patient delivers to this, that is up to the delivery. So obesity is definitely a rising burden, and obesity in pregnancy is not only seen in India, but it is rising globally, increasing maternal and fetal risk. It is defined as excessive or abnormal accumulation of body fat that presents a risk to the health generally diagnosed when a person's body mass index is more than 30 or higher. For Indians, BMI of even 23 is considered the cutoff for overweight, and BMI of 25 or higher indicates obesity. So this is a typical feature of an obese pregnant woman. According to this National Family Health Survey data, in our country, 6.4% women of pregnant who are pregnant, they are having problem with obesity. So as I've said, even becoming pregnant might be a bit difficult for this obese woman as compared to women with normal BMI. This is because it affects the fertility because of menstrual irregularities and decreased egg quality might complicate ovulation and decrease the chances of conceiving in obese women. And of course, we'll be seeing what are the effects on mother as well as baby. There are definitely high risk of complications such as preeclampsia, gestational diabetes, fetal injuries during delivery, so on and so forth. So coming to how it affects the fertility. Obesity leads to anovulation or poor quality eggs. We all know that PCOS is commonly associated with obesity. And we also know that when a woman is having PCOS, the ART success rate is lower because of this obesity related problems. Then obesity during pregnancy, it increases the chances of various complications for both mother and the fetus. These complications range from spontaneous abortions, preterm labor, preeclampsia, gestational diabetes, increased rates of cesarean section, and potential long-term complications, health issues, even in the child. So this are all the complications: preeclampsia, spontaneous labor, increased chance of preterm labor, increased chance of cesarean delivery. It impacts not only the woman but also the fetus because it may affect the breastfeeding as well. So starting from the early pregnancy, there is increased risk of miscarriage due to hormonal and metabolic dysfunctions in this obese woman. And not only that, there is increased risk of developmental abnormalities in the fetus. So this might affect the pregnancy right in the first trimester. There is higher risk of neural tube defects, cardiac anomalies due to poor glycemic control. Many times these are having associated hypoglycemia as well. Then ultrasound accuracy to diagnose anomalies is definitely affected because thick abdominal wall, and sometimes the anomalies might be missed. Then gestational diabetes is definitely, hypoglycemia is definitely more in obese women. They are also prone to have hypertensive disorders. Then placental dysfunctions, it is definitely more common, leading to placental insufficiency. Again, oligohydramnias and fetal growth restriction is more commonly found in babies with obesity, in mothers having obesity. There is increased risk of preeclampsia. It is, in fact, a major risk factor for preeclampsia. Gestational diabetes, I have already said. So it can lead, gestational diabetes itself can lead to number of complications in mother as well as baby. Then maternal risk factor because of obesity, apart from what I have told, is this systemic disorder, thromboembolism. and they may have problems, sleep apnea, and poor surgical outcomes when they undergo cesarean section. Obesity increases the risk of formation of clots, including venous thromboembolism, during pregnancy as well as in the postpartum period. There are intrapartum challenges as well. Like these patients, they are more prone to have prolonged labor. The chances of failure of induction is also found to be more common when the woman is obese. Cesarean section, of course, is more often needed with added complications of surgery and anesthesia. This women, obese women, they are more likely to require cesarean section due to complications like macrosomia, and maybe they might land in prolonged labor. Because of macrosomia, not only cesarean section rate is increased, but when we attempt to deliver those patients vaginally, chances of shoulder dystocia is definitely increased. All the anesthetic complications we can think of, they are more common in obese women. And that is why giving anesthesia to this obese woman becomes more challenging and risky during delivery. Like airway difficulties and other induction of anesthesia in this woman because of short neck or thick neck, more weight. So the drugs also, the calculation also might go wrong when we give drugs for anesthesia. Then problems associated with obesity is right from the beginning, that is assessment by clinicians. When we see this obese women in OPD, right from taking their BP, we find it difficult because regular BP cuff may not be suitable because of large arm circumference, giving erroneous BP readings. Then on palpation of abdomen because of thick obese abdominal wall, difficulty in assessing the size of uterus, and subsequently calculation of gestational age might be erroneous because of the huge fat over the abdomen. Even PV examination findings, we all know, may not be accurately assessed because of thick abdominal wall, it being a bimanual examination. Locating FSH also might be difficult, and we may have to make use of Doppler every time we want to monitor this patient. So this is near term, not even full term, near term patient having problem of obesity. So maternal risk of obesity, they are not over yet. There are many other issues like infections. So wound infections are more common after cesarean sections in this woman. They are even more prone to have postpartum hemorrhage. It can increase the chances of BPH. And this women, they are not only having fat all over the body, but they might be having associated large drooping breasts. So latching might be difficult, holding the baby properly so that the baby can be latched. Even that might pose some technical difficulty. Then not only in the mother, but that there are a lot of complications, fetal complications as well. Maternal complications, maternal comorbid conditions like obesity, depression, they go hand in hand, and this might affect the fetus. So there might be behavioral deficits, reduction in the cognitive and emotional functions. This is proven, that is by a number of studies. This obese women, they are likely to have more stress, and that is adversely going to affect the fetal outcome as well. So this baby is born of obese women. They may have behavioral dysfunctions, cognitive impairment, emotional dysregulation, metabolic dysfunctions, brain alterations. And this might be because of cortisol levels and body fat mass is different in this babies. They even may have long-term effects. These babies which are born to obese women, they are likely to be heavy-sized babies having macrosomia. As I have told you, there is an increased risk of birth injuries when we are attempting vaginal delivery. Especially, we are very much worried about shoulder dystocias in this obese women with macrosomic babies, and they end up with cesarean section. Even doing cesarean section for large babies, it might be challenging. These babies, they are likely to have birth defects more commonly, including neural tube defects. There is increased risk of stillbirth, metabolic abnormalities, as well as developmental abnormalities in these babies. And these babies, when they grow up, they are having increased risk of obesity themselves, and they are likely to become diabetics in future. The incidence of preterm in obese women, that also is found to be higher. And because of preterm birth, it carries its own set of risk for the fetus. The chances of stillbirth is found to be higher in obese pregnant mothers. The chances, because of these complications in the baby, the chances of NICU admission is increased. Then there are chances of hyperglycemia, respiratory distress. And because of all these complications, the rate of neonatal death is definitely higher than other women. Then increased risk in childhood obesity. This also is proven. Exposure to maternal obesity during pregnancy can increase the child's risk of developing obesity and related metabolic disorders later in life. These babies or children born of this obese women, they may have neuropsychiatric issues. There is growing evidence suggesting a link between maternal obesity and an increased risk of neuropsychiatric issues in the babies of this mother. So what is necessary? Now, counseling, even preconception counseling, we can say, is important. Before they attempt to become pregnant, we should advise them to have proper BMI by advising losing weight. They should achieve healthy weight before pregnancy is attempted to reduce the risk associated with pregnancy, delivery, and thereafter. And of course, when we are treating this obesity, the comorbidities also definitely will be controlled. And this is achieved only by lifestyle changes. So it is better to start counseling these obese girls, obese young women, when they are thinking of becoming pregnant prior to their conception. So obesity before pregnancy is an important issue that we have to face. The goal is to try to reach healthy BMI and improve fertility as well as the outcome after becoming pregnant. So this can be promoted by promoting proper diet that is definitely going to promote weight loss and boost fertility. Regular exercises to reduce obesity and strengthen the musculature. Prenatal vitamins may be advised and supplements to regulate hormones and menstrual cycle. That is, before attempting ovulation induction drugs in this obese woman, most of the times they might be even having PCOS. It is better to advise them to undergo lifestyle changes, reduce weight, achieve a healthy BMI, and then attempt pregnancy. In fact, no other treatment might be required if they are achieving the ideal BMI. So it is a multidisciplinary approach that needs to be applied for this woman. So combined care is definitely going to increase the safety and outcome. Maintaining a healthy diet and engaging in regular exercise during pregnancy is crucial for both mother and baby. That is, once they become pregnant, this counseling and lifestyle change should be maintained. Throughout the pregnancy, it is important to monitor frequent and close monitoring of blood pressure, sugar levels, fetal growth is essential because we know these are going to be affected more frequently in this obese women. In fact, they should be given individualized care depending upon their requirement. The recommended weight gain is definitely less in obese women as compared to what we advise 11 kgs for average sized women. So during pregnancy, weight gain should be restricted by asking the patient to avoid certain things like ghee, butter, sweets, dry fruits, fried and fast food, and refined wheat, that is maida, and anything prepared with these items. Then coming to delivery and then postpartum management, we should anticipate that this women, they are likely to land up with some problems. So we should anticipate complications so that we can plan management accordingly. And they should be given even adequate. We have to ensure that they also get adequate postnatal care. They will require specialized care. Women with BMI about 25 should have a pre-conception consultation with an obstetric anesthetist, pre-delivery consultation with an obstetric anesthetist. We should involve the senior staff, nursing staff, that is assistant RMOs or residents, Senior medical staff should be involved in managing obese pregnant women, especially during labor and delivery. So to conclude, obesity during pregnancy is a significant factor, high risk factor for both maternal and fetal complications. So it is better to prevent, prepare, and personalize care for obese pregnant women. Early intervention, healthy lifestyle choices, and continuous monitoring or more monitoring, vigilant monitoring are crucial to minimize this risk and to promote a healthy pregnancy outcome. Obesity during pregnancy significantly increases the various complications for both mother and babies, including diabetes mellitus, preeclampsia, increased risk of cesarean delivery, as well as birth defects, macrosomia, and possible long-term health issues for the child as well. So all these things should be kept in mind, and that is the way to manage the obese woman. Thank you for your patient listening.
Thank you, ma'am. Thank you, ma'am, for such an elaborating and enlightening session on obesity and pregnancy. It is clear that this is not obesity is not just a clinical concern, but a growing public health challenge that demands our urgent attention. Obesity in pregnancy significantly impact both maternal and fetal outcome, from gestational diabetes and hypertensive disorder to increased operative deliveries and long-term metabolic risk for the child. We learned from Zunzar madam that preconceptional counseling plays a vital role. Appropriate weight gain and nutritional guidance during pregnancy are very essential. And as a healthcare professional, we must actively educate, support, and empower women to adopt healthier lifestyle without stigma or judgment. So I extend my heartfelt thanks to Dr. Puspa Junjare madam for her insights and to the audience for their participation. Thank you, ma'am. Thank you so much.
Dr. Sneha, you want some inputs? So thank you so much, madam, for that very much needed talk, which has covered practically all the things. Can we go for the next session? So next session we are starting the next session, where I'm immensely happy to invite my dear friends as chairpersons. So CV, please. Actually, it's a rare joy when friendship walks hands in hand with scholarship. So we all friends are meeting here on some academics forum. So I welcome you all. Dr. Lalita Lokhande. Dr. Lalita Lokhande has a tireless zeal and she has a curious mind. She brings every scientific session to life. She gives so much that it comes live. Her passion of knowledge turns learning into inspiration and efforts into excellence. She's a senior consultant at Daffodil Indra IVF Center, Amravati, senior consultant OBGYN since last 23 years. She works as assistant lecturer at Dr. PDMC Amravati for 10 years. She held the position of Secretary Amravati OBGY in 2025-26, Treasurer AMOX 2020, co-convener team workshop AMOX 2020, Joint Secretary AMOX Zonal Conference to 2016, Adolescent Committee Chairperson Amravati OBGY Society 2018 to 19, past Clinical Secretary Amravati OBGY Society. She received late Dr. Shailaja Chaudhary Award for Academic Excellence in 2012 and 13. She has a special interest in working in the field of adolescent health and counseling since last 10 years, has been invited in many schools and colleges for the workshop and guidance, master trainer of national level program of Foxy for Children, Dhira to promote no violence against women, faculty at many state and regional conferences, and special interest in critical care in obstetrics. She had started a YouTube channel as a secretary of Amravati OBGY, Manthan, Exploring the Iceberg. She has many hobbies and writing poems and columns in English and Marathi. is her special hobby. So I welcome you, Dr. Lalita, for this ICOG session. I welcome Dr. Shalaka Bari. She is at present President OBGY Society Amravati. Dr. Shalaka has various uh, she has various important things on her personality. She is very lively person. Wherever she goes, she takes things so easily that the hardest things seems to be very easy. So I welcome you, Dr. Shalaka. She is a President Amravati OBGY Society, consultant New Best Hospital Amravati, faculty at Rajendra Gode Medical College and Hospital. Areas of interest are midlife mental health, supporting women's health through menopause, and she received Foxy Achiever Award. Her publications are, she was Chief Editor Mindspark Amox 2020, HRP Times, awareness articles in newspaper. I welcome you, Dr. Shalaka. Dr. Rashmi, again, my dear friend, with tireless dedication and national vision, Dr. Rashmi serves Foxy with heart and purpose. Her hard work weaves commitment in the progress, strengthening women's health across the nation, being the chairperson of Practical Obstetric Committee 2527. And she also
Thank you.
had.
Thank you so much.
So there are so many things for you. So I welcome you, Rashmi.
Thank you, Dee.
I request Dr. Lalita to introduce our today's speaker, Dr. Shuchi Jain.
At the outset, I would like to thank Sneha Buyar Madam, Dr. Sheila Mane Madam, Dr. Pranjal Madam and Manisha Madam for this wonderful invitation to chair this session. Now, before we proceed to this session, I would like to just point out that whatever we are going to hear, maybe we may practically not be coming across every single patient in day-to-day practice. But whenever a patient of HIV comes to us, we have to have all our guards at hand, and we must remember this lecture, whatever madam is going to deliver to us today. So this please carefully we have to listen to what she has to say. Now with these words, I would like to introduce our speaker, Dr. Shuchi Jain Madam. She has passed her MD and she is FICOG. She is professor and HOD at MGIMS Sevagram. Presently, she is the president of Sevagram Vardha OBGY Society. She is collaborated to WHO, Sears, and she is a PG guide.
And that's okay. I think we can,
She has
proceed with the talk. Yeah, I think everybody knows.
words. I would like to invite Dr. Shuchi Jain to please start with her talk. Thank you so much, ma'am.
Thank you, ma'am.
Suchi, nice to see you. I think we last met at FIGO.
Yes,
and again, I
ma'am.
am seeing you today. So welcome to this seminar. Yeah.
Yeah. Just one sec. Yes. So at the outset, I would like to thank Sheila Mane ma'am, Sneha Bhuvar ma'am, Dr. Pranjal, Dr. Manisha, so the ICOG and MOG's leadership who thought me worthy of requesting me to give this talk today. I'm very comfortable on my home ground. So playing IPL when you are on your home ground is always easier. So it is very nice to be amongst the Vidarbha groups. And out of the 7H, which Sheila madam had planned for us, the brainchild, Sneha ma'am asked me to take one of the difficult H, and that is HIV positive pregnancy. So I'll try my best to make it easy and interesting. We need to destigmatize the stigma which HIV has brought in the general population. I bring you greetings from MGIMS Sevagram Vardha, my college. So all of us know like what is HIV? It is the RNA virus, but it is a very fragile virus, susceptible to heat, and 1% sodium hypochlorite inactivates the virus. So in all your practicing areas, if you start using your bleaching powder as a universal work precaution, you will prevent the spread and transmission of this virus to the workers working with you. Now, what is the incidence? The people living with HIV is as high as 40.8 million, according to the 224 fact sheet of UNAIDS Global. And what is the scenario in India? So almost 25.44 lakh people are living with HIV, and India is the second largest HIV epidemic in the world, accounting for about 6.3% of people living with HIV worldwide. The HIV prevalence is high amongst the highest risk, and the adult prevalence is almost 0.22%, of which 42% are women, and the maternal to child transmission could be as high as 27.4%. So that is why the interest in HIV has been regenerated. This is how the virus looks like. And when I was looking into the literature, I found out that Maharashtra is one of the high-risk states. And though the western part has more of HIV, yet now it is spreading to the Vidarbha or the eastern part of Maharashtra. It is a lipid bilayer derived from the host cell, and the three enzymes, the reverse transcriptase, the integrase, and the protease, which convert the RNA into DNA. They integrate the viral DNA into the host genome, and then they process the viral proteins during assembly. These are the enzymes which we target when we target the decrease in reduction of the viral load of HIV in a patient. The incubation period 1 to 3 weeks, and after to HIV infection window period of 12 weeks. So this we have to remember. So our patient may have had an exposure and gets the HIV test done, but we need to repeat it HIV positive or not. Now, this is a natural history of HIV infection where a primary infection has occurred, and over a period of 12 weeks, the antibodies will present in the circulation. As in the body, over a period of 10 to 11 years, the CD4 CAR T lymphocyte counts will decrease. So decreasing CD4 is not a good sign. At the same time, increasing of the viral RNA copies, which as they increase, they lead to constitutional symptoms, opportunistic diseases, and death. So increase in the viral RNA copies, again, is not a good sign. So main targets of that producing new virus particle, and that leads to a significant fall in CD4 cells. And the inability of the B lymphocytes to produce antibody to HIV, which causes progressive immunosuppression and ultimately the development of AIDS, takes around 8 to 10 years. So this is how primary infection finally leads to destruction of the immune system by the accelerated virus replication. Now, what are the routes of transmission of HIV? As all of us know, there are sexual routes from male to female, female to male, and male to male also now increasing day by day. And the parenteral route could be transmission of infected blood, sharing of infected needles. But what we are worried about today is the parental route or the mother to child transmission. This accounts for almost 25% estimated risk per exposure without treatment, and mother to child with treatment. This risk in transmission accounts for 5% of HIV positivity. The risk of HIV transmission during pregnancy is 5 to 10%. During labor and delivery, it increases to 10 to 15%. During breastfeeding, 5 to 20%. And overall, without breastfeeding, 15 to 25%. And with breastfeeding, up to 6 months, 20 to 35%. So we as OBGYs play a major role. This is the WHO clinical staging. What is important is, like, as the symptoms increase from stage 1, she can go to stage 2, stage 3, and finally stage 4 of opportunistic infections. Now, what are the factors which are involved which increase the chances of mother HIV infection transmitting to baby? So the factors will be transmission and infection. The obstetric factors could be uterine manipulation, prolonged rupture of membranes, placental abruption, intrapartum hemorrhage, invasive delivery, invasive fetal monitoring, immature immune system, preterm baby, low birth weight, first infant of multiple births, immature GI tract, mouth sores, or an inflamed GI tract in the baby. Now, certain studies have been done and they show that HIV can lead to increased risk of preterm labor, fetal growth restrictions, stillbirth, infant death, and low CD4 count. And the effect of pregnancy on HIV is fallen CD4 count and high RNA levels. So the parental route or the parent to child transmission, this started way back in 1987. And from 1991, we have had very many phases of NACO program. And the latest is the EVTHS, which Mane ma'am was talking about. And that is elimination of vertical transmission of HIV. And along with it, we are now concentrating on syphilis also. So parent to child transmission is known as vertical of parent to or perinatal transmission. The prevalence of HIV rate to fetus is about 30%. It is the main cause of HIV infection in children. So a four-pronged strategy of elimination of vertical transmission of HIV and syphilis has been described under NACP 5. I would like to tell you that NACP 5 actually has ended on 31st March 2026, but the latest guidelines have not yet come into public domain. So we will still just go through what we were talking about till 2026 March. And that is, they have divided it into 4 phases. Prong 1 is primary prevention of HIV, especially among women of children of childbearing age. So women should not get HIV. If they get infected, the prong 2 is preventing unintended pregnancies among women living with HIV. So we need to tell them about the family planning services available, transmission from pregnant women to their children in case they get pregnant, and after delivery to provide support treatment to these infected women and their partners and manage both syphilis and HIV in infants. So the NSAP Phase 5 goals or the EVTHS pillars and strategic framework talks about reduced annual new HIV infections by 80%, reduce the AIDS-related mortalities by 80%. In fact, now under the Sampurna Suraksha strategy, the aim is to reduce annual new HIV infections by 90%, to eliminate the vertical transmission of HIV and syphilis, promote universal access to quality services, and eliminate HIV/AIDS-related stigma and discrimination, which is the main hindrance to giving proper care to these women. So we were talking about primary prevention. So it is the adolescent health or the adolescent group which we are supposed to target at. Prevent HIV amongst the high-risk group and at-risk women, and prevention among serodiscordant couples. So serodiscordant means that one of the partners is positive, but the other is negative. Then communication and communicating and access to preventive services forms a part of primary prevention. The second or prong was family planning and preconception care for HIV positive women. So talk about the family planning services and provide them contraceptives. And then HIV and STI screening should be available at all ANC facilities, and all districts have been replaced by the ICTC name. So it is health and tracking services at which we can do the HIV testing and provide them the pre and post counseling. So referral, once the screening is reactive, you have to refer these cases to the confirmatory and treatment facilities. The viral load testing and the suppression of women living with HIV at ART centers, which again are present at all district hospitals. And the treatment monitoring of syphilis, the infected pregnant women, can be done effectively. And then management of HIV, syphilis, pregnant women, the infant and the child. So the exposed infant has to be diagnosed with early infant diagnosis, and the management of the exposed infant should be done in consultation with the pediatrician. So family planning services form the mainstay because we don't want unintended pregnancies in women who are HIV positive. So these should be provided at the ART center by the counselors, and the counseling, the pregnant women living with HIV on pregnancy planning, if they desire to become pregnant. So if it is an intended pregnancy, we need to give them a proper preconception care to ensure a healthy pregnancy. And nowadays, the fear of HIV was very high when we were postgraduates. But I think now we are having HIV positive mothers coming with babies delivered. So the counselors or the ART may aid in the following: assist couples where one or both partners are infected with HIV and desire to have a child. So if her husband is positive, she can be given Truvada, which is a combination of two drugs, so that she doesn't get HIV and doesn't pass it on to her baby. And the counselors should ensure viral load suppression before they plan pregnancies. They should provide guidance on optimal ART adherence to support healthy pregnancies, and collaborate with the ART medical officer to address anemia and malnutrition concerns. And the counselors are responsible for screening and managing STIs and RTIs in both partners. So counseling in HIV positive pregnant women involves explaining the advantages of ART, adherence to ART, safer sex practices, regular ANC visits, antenatal counseling, care of nipple and breast, nutritional counseling, viral load testing at 30 to 36 weeks of gestation for a baby. So even if she's receiving ART, this testing has to be done at 32 to 36 weeks. Institutional delivery and birth planning has to be done beforehand. ARV prophylaxis should be started to the infant immediately after birth, and provide information and counseling that her baby will be under follow-up till HIV infection is excluded, which could be at 18 months or 3 months after stopping of breastfeeding, whichever is later. Now, counseling for HIV exposed infants would be that they should have ARV prophylaxis, counsel on exclusive breastfeeding for the first 6 months, and continue it up to 12 to 24 months with appropriate complementary feeding. Early infant diagnosis is to be done, and co-trimoxazole preventive therapy is to be given, started at 6 weeks, with immunization, monitoring growth and development, and regular follow-up. So what we are really worried about, our main concern as that prevention of vertical transmission. So it can occur during pregnancy, labor and delivery, or breastfeeding. And a major factor that increases risk of multiple transmission is the viral load. So positive things we could do is ART to HIV positives and AR prophylaxis to a baby reduces the risk of HIV transmission and manifestation. So screening should be done. So all the centers which are there for ICTC should have an effective system where women who are presenting in the first trimester at her first visit should be screened for HIV and syphilis together. So pregnant women at ANC sites, screen them, find out whether they're HIV or syphilis active or non-reactive. If reactive, refer to ICTC and refer to a higher treatment facility. Yeah, I think I got disconnected. Am I audible?
Yes,
Yes,
ma'am.
ma'am, you are audible.
Yeah. Okay, so the laboratory diagnosis are the enzyme-linked ELISA test, and if it is positive, we need to do the rapid diagnostic tests or the dot immunoassay, the immunochromatography, and the immunoconcentration. The Western blot test and antigen detection are for the viral culture or DNA PCR for the women. Now, under the national program, it is recommended to provide lifelong ART for all pregnant and breastfeeding living with HIV receives a fixed drug combination, which is a triple drug ART regimen, regardless of the CD4 count or clinical stage, both for their own health and to prevent vertical HIV transmission and for additional HIV prevention benefits. So presently, as per national guidelines, TLD is the preferred regimen for pregnant women, and this is the best take-home message, which all of us need to take back, that TLD is the antiretroviral therapy which is being recommended. These are the categories of drugs, the one which I was talking about earlier. So the NRTIs are the non-nucleoside reverse transcriptase inhibitors, which acts on the enzymes, and the L stands for lamivudine. NT is the nucleotide reverse transcriptive inhibitors, and tenofovir is the T in the TLD. And then we have NNRTIs. These are the non-nucleoside reverse transcriptase, where efavirenz is given in some of the regimens. And PI are the proteinase inhibitors, protease, and the integrase inhibitors or the dolutegravir. That is in the TLD regimen. So in the pregnant patients, we normally focus on tenofovir, lamivudine, and dolutegravir. So this is how the drugs act. They may prevent the fusion and entry. They may prevent the action of the reverse transcriptive enzymes, the integrase enzymes, and the protease enzymes. And this is how we need 3 drugs acting on 3 different sites to fight with the HIV virus. So it is a combination of 3 drugs which controls HIV replication. It cannot cure HIV or AIDS. It is a lifelong therapy, and it is similar to treatment taken for high BP and diabetes. So no mono or dual therapy, or always give highly active antiretroviral therapy to all women, a triple drug fixed dose combination. So this is the preferred ART regimen for all pregnant or breastfeeding women with HIV, to be given in this dose combination as a once daily tablet. This includes all HIV-1, HIV-2 women who have been exposed to NVP earlier, that is nevaprevin, or co-infected with TB or hepatitis, and they should be educated about the benefits of DTG to help giving them an informed choice. Pregnant women presenting in labor for the first time, no prior ART, the same regimen of TD is to be given to them in intrapartum and postpartum. And these are some of the side effects of the ART drugs. And sometimes the TG drug which we use, some modifications in other drugs need done. The monitoring of women who are receiving this TLD, they should have a continuous CD4 count, hemoglobin, CLC, AAT, and serum creatinine once every 6 months to look for their fitness to receive the next dose, and screening for NC, laboratory evaluation, CD. I don't know, there's some issues. Yeah. Yes, so start ART as soon as possible, continue it and initiate it at the ART centers. And women already receiving ART, if they are receiving the efavirenz based, they should be shifted to the DTG based regimens. There is no indication of abortion, termination of pregnancy in women exposed to efavirenz or DTG. And women presenting directly in labor in the new PPDCT prophylactic regimen, they should be put on lifelong ART if they are positive in the whole blood finger prick test. Co-trimexol prophylactic therapy should be started for pregnant women if the CD4 count is less than 250 Or if they are WHO clinical stage 3 and 4, it prevents the opportunistic infection. Care is given to infected mothers and babies as it is given to other babies. So we do not label them as HIV positive. Follow safe delivery techniques, standard work precautions, minimize vaginal examinations, use aseptic techniques, vaginal cleaning with chlorhexidine, avoid prolonged labor, consider oxytocin to short labor, avoid artificial rupture of membranes, use non-invasive fetal monitoring, support perineum and avoid routine episiotomy, avoid instrumental delivery. Normal vaginal delivery is considered unless the woman has an obstetric indication for cesarean section. Suctioning the newborn with nasogastric tube should be avoided unless there is meconium staining. If required, use a bulb suction. Avoid milking the cord and delayed cord clamping. Cut cord under cover of light gauze. Handle infant with gloves. Clean the injection site with spirit and determine mother's feeding. Infant feeding is as per mother's choice. However, breastfeeding 6 months continue feed twins. We need to give a dual option of syrup nevirapine with syrup zidovudin. So the 6 criteria to assess suitability for replacement feeding is, so if it is safe for them to give replacement feeding and not their breastfeeding, then they can go to replacement feeding. Zidovudin and nevirapine are given according to the doses after the early infant diagnosis. So contraception, now after the delivery, we need to advise them contraception. So contraception in HIV should be dual. Barrier method to reduce the risk of sexual transmission of the virus in combination with combined oral pills, progesterone only pill, and DMPA can be given in HIV and AIDS in category 1 WHO. However, IUCD is category 2 for HIV infected and category 3, so it should be avoided. So these are the methods of contraception under the family planning program, which have been advocated for these women. And monitoring of these women should be maintained by the EVTHS card, and separate cards should be maintained for each pregnancy. So this is how the HIV India response started in 1986. Now we have reached NACP state security. These are the ensuring that 95% of those who are HIV positive in their country know their status. 95% of those whose status are on treatment, and 90% effective viral load suppression, elimination of mother-to-child transmission of HIV, of syphilis, and the most important point, elimination of stigma and discrimination related to HIV. So the model now is test and treat, Mission Sampark, and now it is the Sampurna Suraksha strategy by Government of India. So a big thank you to all of you. I know it's been a tough topic for you also and for me also, but we need to be careful every time a mother comes to us who is HIV positive, and treat her like as being one of us only and not something different. Thank you.
I request chairperson to open the.
Dr. Rashmi has to rush for some emergency. So I would like to give a few comments on the talk. Madam has very nicely elaborated on the magnitude of the problem which we are facing now. And she has very nicely given all the various preventive strategies in all age groups and the various management strategies available for all of us. And highlighting on the various areas in which we can intervene as clinicians to save the transmission of the disease and spread of the disease. She has very nicely covered all the topics right up to contraception. So Dr. Shuchi Jain, your talk was really an enriching experience for me and all the delegates present today. Thank you very much. Over to Dr.
Thank you, Lalita
Pranjal.
ma'am, for your kind words. Yeah.
Yes, Suchi madam, indeed a very difficult and tough topic to be sum up in such a short time. But you did the job so well, madam, as expected. Thank you
Thank
so
you,
much.
Dr. Pranjal.
So I
Yeah.
think this is end of the session too, and I hand over the mic to my dear friend Manisha for further proceedings of panel discussion. Manisha, over to you.
Thank you. Thank you, dear Dr. Pranjal Madam, for conducting this session so nicely. And thank you, all the speakers, respected Somachi Madam and Dr. Suchi Jain Madam. You have enlightened the talk so nicely for all the delegates. And definitely it is going to help us in our practice in coming days. So let us quickly move. Yes. Sheila Mane
Yeah,
Madam.
Manisha, just one comment.
Yes.
Yeah, one commenter. I think Dr. Suchi and Dr. Pushpa, Madam, both of them have done a great job. I think very important topics. That's what, as I told you, that NACO workshop I have attended. So there they said that if you have a young girl and who gets pregnant within 3 months of her marriage, okay, you will do her HIV test everywhere, everything, but she just married, okay, so she may be in a window period, and we
Yeah.
so suppose if we have a young girl who is just married and conceived in 3 months, must repeat her HIV test again, her sister, or get a history of husband's behavior. And emergency cases, if we don't have the report, we wait it, okay, like we do have those kits available, and emergency also we do it whenever there is unbooked patient, because we had experiences where the patients, they have used some that white color this one to erase the results and all that. So, and she was both, she was HIV positive, she was VDRL positive, and after delivery, then everybody came to know there was a needle prick, then the student was, she had to take, okay, so the patient had hidden all the history because she was a migrant. So the problem is now with migrants, because we are getting in Bangalore too many migrants now. And
Yes,
another
ma'am.
thing
It's
is
a
this,
yeah.
okay, so yeah, and one more thing is, suppose if somebody wants to take needle prick injury, they want to take protection, we have to do their test. Without testing them, we are not supposed to give. And once it happened that one of the resident was refusing, he had a needle prick, but he refused to get the test done. So it raised more suspicion. And when the test was done, he was positive. Okay, so I mean, there are so many stories like this because as we think. So these are the two things which I wanted to share. Yeah.
And now they tend to hide results, ma'am. They don't tell when they come.
Yeah, they don't.
That's a major issue now.
Migrant population. So
Yeah.
it's a very big issue for us, because. Okay, thank
And
you.
I think it's a disease of metros now. It's very common now in metros.
Yes.
Very, very, very common. You won't believe there are apps. Okay.
Okay.
There are. I mean, now the so many problems are there. That is, I'm not getting the terminology. We have as we have FSW, like that we have MSW also.
Yes,
And
ma'am.
these MSW, I mean, I'm saying males. There are apps. Okay. And recently it happened that somebody, approached, and those people are not again investigated, and so many problems are there. So the social fabric is broken. So we have to be very careful, I think. The awareness from the schools should go a big way to talk about it and to tell about it. Yeah.
Thank you, ma'am, for your expert comments.
Thank you, Sheila Madam.
Convey my regards to Dr. Poonam. Yeah, convey
Yes,
my regards to
ma'am.
Dr. Poonam. Thank you.
Sure, ma'am. Yeah.
Thank you, Sheila Madam. So as we move forward for the concluding session of this webinar, the panel discussion, which is going to be much, much, much more interesting because we are conducting it on the topic of medical disorders of pregnancy. like anemia, hypothyroidism, hyperthyroidism, and HDP. Again, for this session, we have a very learned, enthusiastic moderator, Dr. Nitika Raghuvanshi Madam, along with the galaxy of our panelists, learned panelists. So can we have the CV of Nikita Madam and the experts, of course, Dr. Sheila Mane Madam and Dr. Sneha Bhuyer Madam will be giving their words in the panel. Can we have the CV of Madam Nikita Madam? Yes. Dr. Nitika Raghuvanshi Madam, she has done her MBBS from Netaji Subhash Chandra Bose Medical College, Jabalpur, and MS from MGM Medical College, Indore. She has received Dr. Reddy's Gold Medal Award for Outstanding Performance in MS in MGM Indore, and had did various training in colposcopy and as well as laparoscopy. And she is at present the Associate Professor and Unit Head in GMC Akola, MUHS approved UG and PG teacher, and many more. She's an MMC accredited speaker and has presented various posters and papers up till now. Her field of interest are high risk obstetric, critical care, preventive oncology, and colposcopy. With this, I request Dr. Nitika Madam to have a word with her panelists and please introduce them. The panelists for today's session are Dr. Madhuri Susodia, Dr. Vasundhara, Dr. Pooja Savani, Dr. Madhuri, Dr. Preeti Javanjal, Dr. Mahavish, Dr. Pranita Revanwa, and Dr. Saili Jagindar. I welcome you all and I hand over to the moderator, Dr. Nitika Madam. Madam, the floor is all yours. Please. Dr. Nitika Madam? Hello. Is Dr. Nitika Madam, have you joined? Has Madam joined? Soham, please, can you confirm?
Yeah, hello. Yes, ma'am. Please tell me.
The moderator, ma'am.
Okay, Dr. Nitika, she had joined earlier. I think she is not. Just give me a minute.
Yes, because I have seen her.
Yes. I also had seen her in the session earlier. I think she's not in the meeting currently.
Yeah, she is not here.
Yeah.
Yeah, but she is the moderator. No, she only will have to conduct.
Please call her. So,
Madam, introduction of the panelists can be done by that time.
Sure.
Yes.
Manisha, can you do that?
Yes. Please
So
share
that will
the
be
list of all the panelists. Soham, let us continue.
Yes.
The panelist CVs. One by one. Yes. Dr. Madhu, she is assistant professor at Mahatma Gandhi Institute of Medical Sciences, and her major achievements are DNB and Global Health and Humanitarian Medicine. She has been awarded, and also the member of National Academy of Medical Sciences, and she had 5 publications. Next. Welcome, Dr. Madhu. Dr. Vasundhara, she is also the assistant professor in the Department of Obstetrics and Gynecology at Mahatma Gandhi Institute of Medical Sciences. Yes. Yeah. Her professional profile, she is dedicated obstetrician and gynecologist.
Hello.
And her areas of interest are laparoscopy.
Ma'am, Soham this side from Core Connect. Ma'am, panel discussion has started and they're waiting for moderator. Yeah.
Welcome, Dr. Vasundhara. Dr. Pooja Sevani, she's an ex-assistant professor at PDMC Amravati and has fellowship in infertility and endoscopy and is consultant at Sevani Maternal Hospital, Amravati. Welcome, Dr. Pooja. Next. Next slide, please. Dr. Madhuri. Yes, she is consultant obstetrician and gynecologist and director of Oxygen Specialty Hospital at Amravati. And she is passionate about making the birth of every newborn a safe and pleasant experience for the mother. Welcome, Dr. Madhuri. Next slide. Dr. Preeti Wadekar, she is consultant obstetrician and gynecologist and director of Shubham Karoti Hospital, Akola. Her qualification, we all know. Her professional position is Secretary of Akola Obigani Society for the year 2013. She is the organizing secretary. She was organizing secretary of Ferticon 2024 and organizing secretary of FM 2025 and the clinical secretary of 2024. Welcome, Dr. Preeti. Next slide, please. Dr. Mehvish, she is then consultant obstetrician and gynecology at Akola. Her professional summary, she is dedicated and experienced obstetrician and gynecologist, and her areas of expertise are OBGYN, high-risk pregnancy care, infertility, ultrasound. With this, I welcome you to the board, Dr. Mehvish. Next. Dr. Pranita Revanwar, she is the director of Chest Hospital and Maternity, Pusad, and secretary of Pusad OBGYN Society in 24-25. Dr. Pranita, welcome on the board.
Thank you, Manisha madam.
Yes. Next slide, Dr. Saili. Yes, she is assistant professor at PDMC Amravati and member of FOXY and ISOPAP. She has held the post of clinical secretary of Amravati in 2008. Again, she has many publications and her special interest is critical care obstetric and high risk pregnancy. Welcome, Dr. Saili. And with this, I hand over to Dr. Nikita Raghuvanshi madam for the further proceeding. Madam.
Thank you very much, Manisha madam.
Yes.
Good evening to all, and thank you for this wonderful introduction of all the panelists. At the outset, I am thankful to Dr. Sneha madam for giving me this opportunity to conduct this panel on medical disorders and pregnancy at the platform of ICOG, and believing in me, and I'm also the respected Bhaskar Pal sir, Dr. Sheila Mane madam, and all other dignitaries who are present over here. With their permission, we are proceeding with our panel discussion today. And the topic for this is medical disorders and pregnancy, highlighting especially on anemia, hypohypothyroidism, and hypertension in pregnancy. As a team, I promise you that we'll engage you with best of our knowledge with the esteemed panelists with me. So let us proceed for the panel. I think my slides are visible.
No, ma'am.
No, okay. Just a minute. Is it visible now?
Your screen is visible. The presentation is not currently on.
Seen.
Yes, now it is visible. Make it full screen, ma'am.
Okay.
Yes.
Okay. So now we'll be proceeding with so these are my esteemed panelists with which we are proceeding with our first case. And the introduction for medical disorders, why we are taking this panel over here is the physiological changes of pregnancy per se, they bring profound changes in the body of a pregnant patient, creating an additional load on various systems. And on the top of that, if she becomes pregnant, the pre-existing comorbidity again enhances the pregnancy complications. The medical disorders like anemia, heart disease, hypertension, diabetes, thyroid, dysfunctions, they further enhance the complications in the pregnancy. So let us discuss some of these problems with our learned panelists over here. My first case is third gravida, para 2 with abortion 0 with a 4-month amenorrhea. Interpregnancy interval is around 8 months to 1 year in between the pregnancies. No use of contraception. She has a complaining of weakness, easy fatigability, breathlessness with mild exertion. No complaint of pain or bleeding per vagina or per rectum. On examination, her vitals are stable. Per abdomen, it is soft, non-tender, and uterus is 16 weeks palpable. When we did investigations, her hemoglobin is 5 gram %, RBC is 3 million, PCV less than 30, MCH and HC is also reduced. So my question to Dr. Madhu, what is your diagnosis?
Good evening, respected faculty members. My diagnosis for this case is severe anemia, ma'am.
Yeah, very correct. It's an iron deficiency. Rather, you can see with the indices also. Now, my second question again to you is this manifestation so normal in the pregnancy? Or what do you think would be the cause of anemia in this patient?
Severe anemia is not a normal manifestation of pregnancy. Physiological hemodilution occurs in pregnancy, but it does not lead to severe anemia, ma'am.
Actually, not so early. It can be there, but not so early. Yeah.
So early. So the cause in this case may be thalassemia, sickle cell disease, or acute blood loss, or maybe iron deficiency anemia.
But we have seen the history that we have seen her 3 pregnancies are in a very short interval. So the interpregnancy interval was very less.
Very less, yes.
Yeah. So she has lost her reservoir and there was insufficient time to replenish it again back. So she was already having pre-pregnancy reservoirs are very less. And on that she became pregnant.
After that she is pregnant.
Yeah. So the reason could be less of reservoir and a superimposed pregnancy on that, creating a hemodilution.
Yes.
Okay. Now my next question is to Dr. Vasundhara. Does severe anemia develops all of a sudden, or if not, then what are the stages of iron depletion and how to pick up them in different stages with different investigations? Is she available, Dr. Vasundhara?
A very good evening to all the esteemed faculty members. Good evening, ma'am. So there can be 3 stages of iron depletion. First, there is iron deficiency anemia. In the stage 1, there is iron depletion. That means the stored iron levels are decreased, whereas there can be low serum ferritin. The iron stores are exhausted, and there are usually no symptoms. Even the parameters are normal. That is, the hemoglobin might be normal in this stage. In stage 2, we can have
Please proceed.
Stage 2, we can have iron deficient erythropoiesis. It means that the iron stores are insufficient, but still there is erythropoiesis in spite of that. So we will have a low, in investigation, we could get a low serum iron, a high transferrin binding saturation, reduced transferrin saturation, and high total iron binding capacity.
Very correct.
So the patient can present with mild symptoms such as fatigue and decreased appetite. In the stage 3, which is the last stage, there can be iron deficiency anemia. It happens due to the iron deficiency, and now the hemoglobin production is decreased. So there is a drop in the hemoglobin as well as the hematocrit level with a low mean corpusculum volume, and the symptoms can be exaggerated that she can have extreme fatigue and shortness of breath.
Very correct. So it's not like that we do not have time to pick these patients up. What is missing over here is the right type of investigations that we are not giving to them to pick this previously, like in preconceptional counseling when she's coming after 2 pregnancy and we are not seeing what is her reservoir before she becomes pregnant. So we can pick up these patients earlier if we are addressing the proper investigation at a proper time. Okay. Now my next question is, what are the effect of pregnancy on anemia? Dr. Pooja?
Good evening, ma'am. Effect of pregnancy on anemia. Pregnancy can worsen the pre-existing anemia. As we see, there is usually the physiological hemodilution occurs during the second trimester, but as there is physiological dilution because of the plasma volume increases more than the RBC mass, but we also see there is an increased iron and folate demands due to the increasing demand for the fetus development and placental development, and also increase in RBC mass. So there occurs increased demand of iron, and there is usually means there is earlier anemia. So it may worsen and increase fetal and maternal complications that may occur. And as the patient is already there is a short interpregnancy interval, it may lead to more worsening of anemia and lead to complications of maternal and fetal complications.
How does diet affects it? Is there any correlation? Like
nutritional deficiency occurs if the patient is not in a proper diet. Then there will be iron depletion, there will be folate and vitamin B12 deficiency due to nutritional anemia, and also protein deficiency that may help in globulin and globin albumin formation, where that helps hemoglobin rise. So all these things will also hamper anemia states.
We all know that if a woman becomes pregnant, the eating is a really nightmare for most of them, because it's the pregnancy induced vomiting that is creating a lot of havoc, the hyperacidity, which is also creating a much of problem that they do not have a kind of feel of eating. And in the later ends of pregnancy, the epigastric, the uterus is so enlarged that the fulfilling senses come very early. So besides that, if we are using frequent antacids, that also hampers the absorption of iron, which we are already providing to them. Besides this, we many times do not evaluate them for the chronic infections, like
chronic infections and hookworm infestations.
Exactly. So asymptomatic bacteria, which is running in the base, also creates a lot of problem with anemia in these patients. Very correct. Then we already seen that the pre-existing reservoir, if it is less, that also creates a problem. Sometimes there is problem with the pregnancy, that the demand is very high. If we are dealing with triplets or twins, these are the conditions where normal requirement is not meeting that demand, which has been increased manyfold. And if we are dealing the pregnancies where the interpregnancy difference is very less, we may encounter the women who have already undergone PPH and excessive loss in their previous pregnancy, which has not been addressed at the time of their discharge. So they are having already less reservoir, and on that they become pregnant. So these are some practical problems. Now, my next question is how to classify the anemia on the basis of different parameters. I'll ask Dr. Madhuri to address it. Dr. Madhuri? Unmute yourself.
Unmute yourself, Madhuri.
Are you able to hear, Dr. Madhuri?
Please unmute yourself. Your mic has been switched off. Yeah, now it's okay. Now you can hear? Yeah.
Am I audible, ma'am?
Yeah, you're audible. You want to repeat the question?
No, ma'am. I could hear.
Okay.
Good evening, everybody. On the basis of basically the size of the cells, we can distinguish the type of anemia. Like if the cells are small, they are microcytic. If they are normal size, or if they are macrocytic. So in this case, in this particular patient, it is mostly likely to be microcytic hypochromic, because most likely it is to be iron deficiency anemia. Other causes can be thalassemia and even blood loss for this patient, because multiple pregnancies without restoring the iron stores.
Very correct, very correct. So it's like degree of anemia, type of anemia, and cause of anemia. So in degree, we assess the severity of anemia, how severe is the anemia. In type of anemia, like you said, microcytic hypochromic or macrocytic anemia. So we see the type of the cells, which type of anemia it is, and on the basis of that, we assess for the cause. And third is the cause of anemia, where something else is creating, like pernicious anemia, like absorption, malabsorption disorders, like sickling disorders. So these are the diseases or chronic infections. So they are actually the cause of anemia. So we have to address those causes before correcting the anemia. Now, I just want to ask you only, what are the investigation that is to be done to know the degree of anemia?
Mainly, basically the CBC to know the hemoglobin level, the hematocrit level, and also the RBCs. And then a peripheral smear to know the type of cells. To know
We
the
specify this much only, degree only. We'll ask the next panelist about that. You be concerned to the degree only. Yeah.
Yes.
So how has been the WHO classification goes for?
The degree of anemia is classified into mild, moderate, and severe. Mild, the normal level is more than 11 gram%, and
Exactly.
mild is 10 to 11. Moderate is from 9 to 10, and severe is less than 7. Moderate is 7 to 10, and severe is less than 7.
And a very severe is less than 4.
Yes.
Okay. Now, what are the investigations that has been done to know the type of anemia? Dr. Preeti?
Hello, good evening, everyone.
Good evening.
First of all, to know the type of anemia, ma'am, we will go for peripheral smear so that we can judge whether it is iron deficiency anemia, whether any sickle cell RBCs are seen or any other types of anemia that can be basically investigated basically on peripheral smear itself. And then other investigations, we will go for HPLC, that is for knowing some
in peripheral, you can see in megaloblastic, which
megaloblasts, yeah, microblast that we will see, and then Howell-Jolly bodies or any giant polymorphs, something like that. And other investigations, we will go for this HB electrophoresis to know the
that is for
sickling or
timing. Here we are like
serum ferritin levels, hematocrit indices,
okay.
MCH, and yes, basic PCV that we'll see.
Okay, so just to make it proper to understand, first test is peripheral smear. We can see, identify the cell on this and can classify it as an iron deficiency anemia, looking into anisocytosis, poikilocytosis, and polychromasia. You can also see hypersegmented neutrophils, macrocytes, giant polymorphs, and Hall-Jolly bodies. Then you label it as megaloblastic erythropoiesis. If you're seeing sickle cell, target cells, and a refractory hyperchromic anemia with persistent reticulocytosis, it could be a sickle cell anemia. Now, the second important parameter is hematological indices. So here you see the RBCs, the PEC cell volume, mean corpuscular volume, MCH and MCHC. So these are the normal parameters. And if you see in iron deficiency, megaloblastic, sickle cell, and thalassemia, you can have the different range. Like MCV is very high in cases of megaloblastic anemia, while it will be low in rest of the other. If you see MCHC, it is very specifically low in cases of iron deficiency anemia, and rest 3 parameters will be absolutely normal. So there are certain tests which are going to differentiate each of them. Indices. Now comes the serum iron, as Preeti has already mentioned. And here we can see the normal range is this. And if you are encountering an iron deficiency anemia, the serum iron load is reduced to less than 30. Total iron binding capacity increases to more than 400. Percentage saturation drops by less than 10%. And the serum ferritin is somewhere less than 30. Now my question is to Dr. Mahvish. What are the investigations that is to be done to know the cause of anemia?
Madam Nitika,
Yeah.
sorry to interrupt.
Yeah.
Can we go fast because we are short of time?
Okay, fine.
Yes, we have to cover a vast major of topics.
Yeah,
No?
I already asked Madam what is the time assigned to me. She told me 40 minutes. So I said, okay.
No, yes, 40 minutes, but then because we have to deal with so many topics, no?
Okay,
so that's
fine,
what
fine.
I'm worried about.
Sure,
Yeah,
sure.
so you can skip
So,
few slides and cover the other topics also.
okay, fine, fine, fine.
Yeah,
So
thank you.
to know the cause that we have already discussed here. Now, Mahvish, if she's there, can she take this question?
She has not joined.
Mahvish has not joined. Okay. So Dr. Pranita. Yeah, this is for you. How to manage? Do we need to hospitalize her? Which route of therapy? And what is the role of blood transfusion?
Less than hemoglobin 5 grams, no, madam?
Yeah, 5 grams.
Sir, we prefer blood transfusion, madam.
Okay. Do you have a lot of time? It is second trimester. Don't you prefer IV parenteral
Yeah,
therapy?
yeah. If patient is interested, IV oropharynx also I give the choice for patient. And oral medicine and also diet.
Okay, okay. Now, the next question is to Dr. Saili. What is the safety of parenteral iron, the dose calculations, and what are the various preparations that are available in the market? Please unmute yourself, Dr. Saili. Is she there?
Ma'am, I think she has also not joined.
Okay. So, no, she's there. I can see
She
her.
is there. She is there.
Yeah. Dr. Saili, please unmute yourself. Please unmute. Dr. Saili, please unmute.
Hello?
Yeah, now you unmuted.
Ma'am, actually, I was held up in an emergency. I've just joined back. Can you repeat the question?
Yeah, sure. What I'm asking is, what is the safety of parenteral iron therapy? How to calculate the dose of iron sucrose, and what are the various parenteral iron preparations available?
Ma'am, coming to present line preparations, we have 3 of them. One is iron dextran. The second is FCM, that is ferric carboxymaltose.
Yeah.
And the new one that has come is I13.
Yeah.
So coming to iron sucrose, the way we calculate it, like the normal HB, if you take 11 gram, you minus it from the patient's hemoglobin.
Yeah, that is deficit hemoglobin into...
Yes, the deficit hemoglobin multiplied by 100, and then you add to it 300 milligram of iron.
Okay. So, rather we use 1000 milligram for reservoir and 2.4 into the target hemoglobin minus the actual hemoglobin multiplied by weight in kgs. So that will be the way in which we can calculate it. Okay. How does anemia affect the pregnancy, Dr. Madhu?
Anemia has antepartum complications, intrapartum complications, and postpartum complications, ma'am. It leads to fetal complications as well. During antepartum period, it may lead to preterm delivery, preeclampsia, intrauterine death, or maybe infections. During intrapartum period, there may be prolonged labor, increased risk of operative delivery, fetal distress, abruption. During postpartum period, it may lead to PPH, puerperal sepsis, lactation failure, pulmonary thromboembolism, subinvolution of uterus, and postpartum depression. In fetus, it may lead to low birth weight, prematurity, infections, congenital malformations, neonatal anemia, and abnormal cognitive development.
Very correct. Now, can we prevent it, and if yes, how? Dr. Vasundhara? Dr. Vasundhara, are you there?
Hello, ma'am. Can you repeat the question, ma'am, please?
Sure. Can we prevent iron deficiency anemia? If yes, what are the ways?
Yes, we can prevent the iron deficiency anemia. The first foremost step is to screen the anemia. So we should do screening during antenatal period, and we should give prophylactic iron therapy. So prophylactic iron therapy, we give elemental iron in dose of 60 milligram per day with folic acid 400 microgram per day. So as per INEP, it has to begin 180 days. It has to be given 180 days during pregnancy and 180 days during postpartum period.
Yeah, and the better way is that you address them before antenatal, like premarital and preconceptional period. So at that time, you have to assess for the reservoir. If less, then restore it, and so that in pregnancy you'll not have much of the problem.
Yes.
And the other strategies could be limiting the childbirth, proper contraception counseling. That can also be added. Now we move on to our second case, and I would like Dr. Pooja to address this. It's a BOH case, previous 3 spontaneous abortions. She has come for preconceptional counseling now. Her BMI is 35.
Dr. Nitika?
Yes.
Dr. Nitika?
Yeah.
Yeah. I think everybody discussed very nicely. Just one submission now. Anemia, moderate anemia, if we have diagnosed it in second trimester,
Yes, ma'am.
we have to treat it effectively, and that to wait IV FCM. I mean preparations, because the neurological development of the baby is happening. And there is a study done by Kelly where they found, and even post delivery they have done the MRI of the brain. Okay, so it is very important. I think the correction of anemia in early period of pregnancy, even moderate anemia, is equally important. So it should be corrected with IV only. Yeah.
Very correct note that you have given us all. It's very true that the baby has been affected with autism and even schizophrenia. So this take-home message is very important from Mane madam, that we all should understand that correction is very, very important whenever you encounter them in the period of ANC. And even before ANC, if you have the opportunity to pick them up.
Yeah, of course.
Thank you, madam, for your insight. Now we are moving to our next case, that is case number 2. And she is, I think Dr. Pooja is here. Okay, Dr. Madhuri, if she's not there. Dr. Madhuri?
Yes, ma'am, I'm there.
Okay, so do you take, please take this case. It's a case of POH. 3 spontaneous, okay, you are there, Pooja. 3 spontaneous abortions with, she now came for preconceptional counseling because of these losses. Her BMI is 25, TSH is 38, and T3, T4 is 0.4 and 1.2. All other investigations are within normal limit. So how will you proceed with her?
This is actually looking at the parameters, TSH more than 38 with T3, T4 levels also reduced. This is almost a case of overt hypothyroidism.
Correct.
And also she has previous history of 3 BOH, that is 3 abortions. So in the preconceptional counseling, we have to deal with the thyroid. It is mostly hypothyroidism. So we should correct the hypothyroidism first, and we should counsel her about her correction of the hypothyroidism before going for conception.
Very
She
correct.
should not go. She should not conceive before getting new thyroid state. And for that, we have to investigate her again. We can consider re-investigating her thyroid function test. We can also see whether it is by investigating her ultrasound for goiter, and for any of for other things like other investigations for BOH. Also, we can go apply and all, and we should start drug, that is levothyroxine.
I will come to that. What is the drug of choice for hypothyroidism during pregnancy and how to prescribe it? Dr. Preeti?
Drug of choice is, madam, levothyroxine. And yes, basic level we have to maintain in first trimester is 2.5, and second and third trimester is said, it has been said that 3 we have to maintain. So depending on the weight of the patient, that sometimes we have to go for higher dose, but basically we will go as per 1.6 microgram per kg body weight. We have to calculate the levothyroxine dose.
Correct. Now my next question is what one should know about the pharmacokinetics of this drug. Preeti, you only take it.
Pharmacokinetics, madam, that we have to take it empty stomach. One thing that we have to go, because acidic pH promotes the absorption of the drug, and a few other things that we cannot take it with calcium. Some nowadays weight reducing drugs like orlistat and all, and some other drugs like antacids, mainly digoxin and all.
Correct. The drug is mostly absorbed in jejunum, and it is eliminated 80% in urine and 20% stool. And you have to avoid any other drugs along with this because it reduces the absorption. Very correct. What if a woman misses her tablet? She should take it immediately.
Whenever she remembers that time, she can take, and the next day, as per the schedule, she can go with that next tablet.
Exactly. After taking the tablet, she should not consume anything for at least half an hour to 1 hour.
At least half an hour.
Exactly. Right. Now, what are the common medications that interact with levothyroxine?
Antacids, madam, and calcium.
Yeah,
Then,
calcium iron antacids. Then
yeah, LMW, heparin and all also interacts with the thing.
so yeah, warfarin,
Then
it's like its
warfarin,
activity.
yeah, warfarin.
Anticonvulsant, they reduce the effect of levothyroxine. So you need to increase the dose if patient is on anticonvulsant.
Yes,
And
and orlistat also.
yeah,
Orlistat, heparin, yeah, that.
insulin dose is also increased if
Insulin
the
dose is also
patient is
increased,
on that.
yes.
Yeah. So we have to remember that if she's having comorbidities, then we have to change, may be required in the doses. What is the target preconceptional level of TSH for women with overt hypothyroidism during pregnancy? Dr. Saili?
Ma'am, the target is, it should be at least 2.5.
Correct, correct. Preconceptionally. What about the different trimesters?
Different trimesters, I'm not aware, but they say average it should be 2.5, because when you do a thyroxine level, they vary, they have a diurnal variation. So it differs from day to day. So average, you should take 2.5.
Yeah, so it is, if it is preconceptional in first trimester, it has to be less than 2.5. In second and third trimester, 3 micro international units is okay, but it should never be less than 0.1. So that you have to take care. Do we need to titrate the dose of levothyroxine after she conceives, and how frequently the testing should be done? Dr. Madhu? Is she here?
Yes, ma'am. Yes.
Yeah, yeah.
Yes, ma'am.
She
The
is
dose
already on. She's already on tablet, and she has come to you. And if her she's in first trimester and her TSH is more than 2.5, how much dose you'll increase?
Ma'am, we'll increase the dose by 25 microgram. We will add the dose of 25 microgram to the there is some echo going on, ma'am. So
Somebody is like putting.
Hello. Am I audible?
Yeah, you are audible. You are audible.
Yeah, so we need to increase the dose by 25 microgram, and we have to get the test repeated every 4 weeks. So suppose if patient comes after 4 weeks again with TSH more than 2.5 in first trimester, we'll again increase the dose by 25 microgram. And in second and third trimester, we have to maintain the level of TSH below 3 micro international unit per ml. So we'll titrate the dose by 25 again.
Exactly. How will you titrate the dose of levothyroxine after delivery?
After delivery, ma'am, if the TSH level is more than 10 milli international unit per liter, then we have to continue the recommended dose. If it is between 3 to 10, then we have to stop the treatment. And if the patient was hypothyroidism before pregnancy as well, then we have to start the same, resume the same dose again. And it has to be repeated 6 weeks postpartum period.
Right, right. What are the maternal implications if you do not diagnose and treat hypothyroidism in pregnancy? Dr. Pooja?
Yes, ma'am. If we do not, if it is untreated, then in the mild to moderate cases, it can be hyperemesis gravidarum, irritability, anxiety, and palpitations. But in the pregnancy, later pregnancy, it can be early pregnancy loss, RPL, preeclampsia, just and placental abruption, and later postpartum hemorrhage and sepsis and all.
Very correct. Very correct. Is universal maternal screening is required or mandatory?
Universal pre-pregnancy is not actually done or mandatory, but as we are dealing with the cases of infertility, subfertility, ART centers, and any high-risk patient, previous known hypothyroidism, or the age, obesity, in all these high-risk situations, we should go for TSH level at least pre-pregnancy.
Very correct. Very correct. And what about the fetal implications? If you are not diagnosing, what can be encountered in the fetus?
Actually, fetus depend in the early trimester completely on maternal thyroxine. So fetus may suffer low birth weight, IUGR, and growth restriction, prematurity, preterm prematurity may occur, or even brain maturation is dependent on thyroxine level. So neurocognitive effects may happen to the baby later on.
Very correct. Is universal neonatal screening mandatory, Dr. Madhuri?
Yes, ma'am, because there are various effects on the newborn. So neonatal screening is mandatory because in the early phase after delivery, there are no symptoms. As the child develops, then there can be delayed milestones and all. And so we have to screen for the babies of hypothyroid mothers. Generally, it is done between 24 to 72 hours with a heel prick method.
Very correct. Yeah. And what are the tests that are being asked for?
The thyroid profile TSH, T3 and T4. Free T3, free T4 and TSH.
Okay. If the patient is coming to you in first trimester and her TSH is more than 100, would you advise MTP, Dr. Preeti?
Actually, it is not, we cannot say them. We can just give them the options that these are the possibilities. And if we are treating it with high doses, we can control the thyroid immediately. But as per se, directly, we cannot tell them that it is 100 and then you have to go for termination only.
Exactly. Correct. You have to screen till the time the
Yes.
state of euthyroid is achieved, and initial treatment should be with a higher doses. Very correct. Respected Mane madam, I would like to put your insight for this case. Dr. Mane madam, are you with us? Okay.
Yes, Nitika, tell me.
Yes. Yeah. So we have covered the case of hypothyroidism. What are your insights for that for us?
Just hold on. I think even if you find that somebody is there with a very high TSH, we have to counsel them. As such, the incidence of cretinism is not so high, but all the other things like IQ and all these things might get affected. So it is, yes, we have to proceed and do the correction as early as possible. We should also get the TPO antibodies done because sometimes what happens, we stop the medication after delivery and then suddenly it flares up. So here it is overt anyway. But if we find that TPO antibodies also need to be done, because in that case, they will have to take it lifelong if the TPO antibodies are positive, and they should not stop it. Yeah.
Thank you. Thank you very much, ma'am, for your insight. Yeah. Now we are proceeding with our third case, and she is Mrs. ABC, 21-year-old, thin-built, primary, 8 weeks amenorrhea. TSH is less than 0.01, T3 is 3.5, and T4 is 20. All other investigations are within normal limit. I want Dr. Pranita to take this question. Is she here, Dr. Pranita? Dr. Saili, please proceed.
Yes, ma'am.
What is your diagnosis? What is the drug of choice and its doses? Safety in pregnancy and lactation.
In this patient, the TSH is much below the normal limits. That is, you said 0.05.
Yeah,
And the T4
0.01.
levels are increased.
Yeah.
Sorry, 0.01. Sometimes, very rarely, the TSH may be suppressed because of the normal beta SHG levels, but then you should go for free T3, T4 levels. If the free T3,
Right.
T4 levels are also high, then she will fall into category of hyperthyroidism.
Correct. What is the drug that you are going to prescribe her in first trimester?
In first trimester, usually we will avoid methimazole. We will give her PTU.
Very correct.
In the dose of 0.1 milligram per kg body weight. So it's we usually start with the lowest dose, that is 25 milligram of PTU.
Okay.
And that we can give in divided doses.
And after first trimester?
After first trimester,
you'll continue with PTU or you want to shift her to some other medication?
I'm not aware, ma'am. Maybe because we usually continue with PTU only.
Now, PTU has got a very high risk of liver injuries. Like it is liver insult is very high with PTU, and this is the third most cause of liver transplant in USA because their Graves' disease is very high, and they are putting the patients on the treatment. So in first trimester, because the methimazole and carbamazepine are not safe, so you give PTU, and once the first trimester is over, you switch over to methimazole and carbamazepine. Okay. Now. What was the reason why you said that methimazole is not being preferred in first trimester?
It is known to be teratogenic.
There is an embryopathy risk which is assessed, and it's known as aplasia cutis that has been created by methimazole. And what are the doses of methimazole in antenatal period from second trimester onwards? Do you know it?
Not aware.
Okay. So if it is a mild hypothyroidism, you can start with 5 milligram 8 hourly. If it is moderate, then 10. And if it's very severe, then 20 milligram 8 hourly can be given. And then you can put her on maintenance doses once you achieve the euthyroid state. Okay. Now, how do you differentiate physiological gestational hyperthyroidism from Graves' disease? Dr. Madhu? Is she here?
Yes, ma'am. Graves' disease is an autoimmune disease and it has usually have positive family history. It will be associated with clinical features like tremors, restlessness, and there will be markedly increase in free T3 and T4 level. While in physiological hyperthyroidism, there is no family history. Physical symptoms may be absent or may be very mild, and free T3, T4 may be normal or borderline raised.
Very correct. Very correct. And what are the adverse effects of hyperthyroidism on mother and fetus?
Ma'am, to mother, it may lead to abortion, premature labor, stillbirth, heart failure, preeclampsia, low birth weight, and thyroid storm. In fetus, it may lead to congenital malformations, neonatal death, intrauterine growth restriction, or fetal hypothyroidism.
Very correct. Very correct. So this was the case with hyperthyroidism. Now, if they allow us, we can proceed with the case 4. Do we have time to proceed with case 4? Let us
You can take the salient features and finish off.
Okay, fine. So she's a 30-year-old third gravida, para 2 living 2 women with a 34 weeks pregnancy. Came in emergency with the complaints of headache. On examination, her BP was 460 by 110 millimeters of mercury and her urine albumin was 2+. So, Dr. Pooja, what is your diagnosis?
Looking into the parameters, she is a case of severe preeclampsia with also she has headache, so it can be impending eclampsia.
Very correct. Now, what are the other additional points that you want to add in history and examination? If this, she could be with you.
We should ask history of blood vision, epigastric or upper abdominal pain, urine output, degree and duration of severity of headache, how much was it? Then fetal movements, and then any breathlessness or chest pain that can happen in impending eclampsia. And in examination, we should go for complete blood count, then LFT, RFT.
No. Examination, not investigation. In examination.
In examination, we should go do BP and blood pressure monitoring. Then
how frequently
it should be repeated every 4 hourly.
Yeah.
Then to start with the drugs like antihypertensive and Mexel, we should do all the investigation and all the examination needed, like whether she has proper urine output, 24 hours urine output, we should calculate. And all the reflexes.
Okay. So come to the next question. What is an immediate management?
I would just
Yes, madam, please.
Nika, I would just like to add.
Yeah.
Yeah, always look for oxygen saturation and respiratory rate.
Very
because if it is 95 and below, patient is in early pulmonary edema.
Very correct.
So oxygen saturation is very, very important, and respiratory rate. These two things should be there in our protocol, because the day before yesterday, my patient just started desaturating and collapsed.
Oh.
Then we intubated, and you know how pulmonary edema flares up.
Definitely, madam.
Right? So saturation on admission 1 hour prior, her saturation was 95. That was a warning sign.
Yeah,
that was a warning sign. Okay.
Definitely.
So I wanted to give that message that oxygen saturation is very, very important, and respiratory rate.
It was really a very prompt and crisp message that is coming from your side, and I have covered it in my next coming slides. Okay.
Okay, okay, good.
Yeah. What is the immediate management in this patient, Dr. Madhu?
So, ma'am, we have to control the hypertension in this patient, and then we have to give a prophylactic anticonvulsant, and we have to expedite the delivery process. So, to control the hypertension, we can give injection labetalol as BP is she is in hypertensive crisis. So, and as anticonvulsant, we can give injection magnesium sulfate, and we can expedite the delivery process.
Yeah, I just want, what should be the normal for you if you want to control it? What should be the baseline for which you want her to come? She is at present 160, 110. What will be normal on which you want her to come?
BP should
you are I think there is a problem with net. We are not able to listen you. Hello. Okay. Can anybody edit? Siley?
Ma'am, the BP, you should not let it go below 140/90. So you don't want to reduce the BP drastically. It should go down gradually because that patient is attuned to that blood pressures.
Very
so
correct.
Sudden fall of BP is going to affect the baby.
Yeah. There could be complications like abruption that
BP should not be less than 140/90, and that also it should be a gradual
reduction. Yeah. What is hypertensive crisis and which antihypertensive drug to be preferred and which route? You only take this question.
Suppose if a BP is 180, 110 or like that, so it's called a hypertensive. We use IV level.
Hello.
We start with IV labetalol.
Yeah.
20 milligram.
Yeah.
Intravenously. And then you check the BP after 10 minutes.
Yeah.
If the BP remains same, you have to increase the dose to 40 milligram.
Very correct.
Then you check the BP after 10 to 15 minutes. If it remains the same, you increase the dose doubly, that is up to 80 milligram.
Very correct.
Usually it is seen by 22 or 40 milligram, the BP starts reducing. So then you can continue with the same dose till she reaches the target BP of 140/90.
Right, right. What could be the second choice? If you're not with IV labetalol, can we have any other choice to deal with this crisis?
Second choice, usually the BP settles with IV labetalol.
But we are not having IV labetalol. Then what we can use is capsule nifedipine can also be a good option.
Capsule can be used, but we don't give sublingually, we'll give it orally.
Exactly, exactly. Very correct. So it is given in a dose of 10 milligram, repeated every 10 to 20 minutes in the form of 20 milligram, and repeated doses of 20 milligram only till you achieve your target BP or the maximum dose of 90 milligram has been reached. So this is how you have to manage it. And there are other drugs like hydralazine, nitroglycerin, and sodium nitroprusside, which we usually do not use. And the above two medications can only the best performers in our day-to-day activity or practically. So now the next question is, how will you proceed with seizure prophylaxis in this case?
Recent guideline of Nitika, recent guideline of oxygestosis is also included IV nicardipine. IV nicardipine.
Okay, okay, okay.
Okay, I will share with all of you the recent guidelines.
Sure, sure, madam, sure.
Yeah,
sure.
so IV nicardipine is also there.
Okay, okay. Dr. Vasundhara? Dr. Vasundhara, are you there?
Yes, yes, ma'am.
Can you please take this question? How will you proceed with seizure prophylaxis in this case?
Yes, ma'am, sure. And for seizure prophylaxis, we will give anticonvulsant therapy to the patient in the form of magnesium sulfate, which is the most common drug used for prophylaxis as well as treatment of eclampsia. So there are different regimes that we have an intramuscular regime. Also, we have an intravenous regime. So in the settings where IV infusion pumps are not available, we follow the Pritchard regime. In this, we give 4 gram 20% IV loading dose along with 10 gram of IM, 50% intramuscular injection of magnesium sulfate as a part of loading dose. Then for maintenance dose, we give 5 gram IM 4 hourly in the alternate buttocks till 24 hours or 24 hours from the last seizure episode.
Very
then
correct.
the other regime is we have Zolpan or a CBI regime. In this, we give a loading dose of 4 to 6 gram IV slow over 20 minutes, followed by maintenance dose of 1 to 2 gram per hour IV infusion. We also
Correct,
have
correct.
other regimens like Dhaka, which are low dose regimens.
Yeah, very correct. Now, what are the precautions that should be taken while using magnesium sulfate therapy? You only answer it.
Yes, ma'am. So we have to monitor certain things, certain parameters when we give magnesium sulfate to the patient, because the patient is at high risk for developing magnesium toxicity. So what we do is we see the respiratory rate, we monitor the deep tendon reflexes, we monitor the urine output of the patient. So before giving magnesium sulfate, we should see all this baseline, that if it is normal or not. If there is presence of knee
Very
jerks,
correct.
what is her respiratory rate? It should be more than 12 per minute. What is the urine output? What is the blood pressure?
Very correct. Preeti, how to
Yes,
identify
madam.
the magnesium toxicity and its management?
If respiratory rate is increased and then deep tendon reflexes are not getting elicited, urine output is decreased, so that is suggestive of magnesium toxicity. And yes, if it is possible to get serum magnesium levels, so that also can be, but clinically we can judge with all these points. And yes, to reverse the condition, we can give calcium gluconate 10 ml as IV infusion.
Very correct. And if you see, the therapeutic level is 4 to 7, and the toxicity starts when the level moves above 7 milliequivalent per
Above
liter.
7 milli,
So
yeah.
it's very close phenomena that we have to understand it. And if it is more than 10, then there is a respiratory depression. If it is more than 25, then there is a chest pain and heartbeat. And as madam has already said, pulmonary edema, SpO2 less than 95, you should have the check on this, right? Okay.
So in that case, diuresis immediately can be considered if saturation is going below 95.
Even for toxicity, also fluid therapy and forced diuresis is needed so
Forced
that you can
diuresis, yes.
remove it out. Yeah.
Yes, madam.
How will you proceed in obstetric management in this patient? You only take this?
Yes, madam. If BP is getting controlled initially, as it is a 34 weeks patient, we'll like to go for betnazole and this thing. But still, if BP is rising, then we will have to consider for the termination at higher center, where
Very
all the facilities, ICU availability is there. There we have to go for the termination. And better to go for LSCS, as how the pains increases, patient may not tolerate the other things. So better to go for emergency LSCS in that case.
Yeah, that depends upon the condition of patient. Like
Yeah.
she's vitally fine.
Yes.
Yeah.
If she
her
is
bishop
BP is getting controlled, noxious signs are not there, then and bishop score is proper, then in that case we can go think of inducing also. And like gravida status, like multi, then she will have a short labor. So that case we can go for normal labor, normal delivery also.
Exactly. Now, what is the place of expectant management in severe preeclampsia, Dr. Pranita? Is she here, Dr. Pranita? Okay, Dr. Saili?
Yes,
is there any role of expectant management in severe preeclampsia?
Actually, there's no sort of expectant management unless if the gestation age is very less, say maybe 28 weeks, and you feel that all the symptoms of preeclampsia, they are completely controlled, then sometimes you can go for till the patient is getting steroid cover. And if you think that the symptoms are getting controlled, till you can try to increase up to 48 hours for the action of the steroids has taken place.
Yeah. See, sometimes
so
what
only
happens...
wait for the steroid action. But otherwise, there's no role of expectant management.
Yeah. So the role of expectant management is very limited with very high justification and judiciary monitoring, because sometimes these patients could be an IVF conceptions. And if they have reached to a gestation age somewhere around 26 weeks, and the fetal weight is around 800 grams and all. So what is the aim, that if you are taking a bargain period of 1 to 2 weeks with a very prompt monitoring, and intervention immediately whenever danger signs appear. You can take this utilization of this window of control of blood pressure and can give her a justice when the gestation age is more than 28 weeks or the fetus is more than 1 gram, and it can be survive in a good neonatal care. What are the complications that can arise in severe preeclampsia patient, Dr. Saili?
She may land up in eclampsia, but usually we will try and see that she doesn't go in eclampsia. Second is she may land up in pulmonary edema. There are very high chance of pulmonary edema. Third is she may have some retinal complications like detachment of the retina. Next, she may go in for cerebral edema.
Very correct.
And multi-organ failure of, say, liver failure or acute kidney failure.
Yeah, HELLP syndrome, DIC.
HELLP syndrome.
And then PRESS, that can also be seen, right? Okay. And fetal complications?
Fetal complications, most of the times, these patients who are having early onset of preeclampsia may have IUGR. They may have fetal distress, meconium staining.
Prematurity, RDS.
Prematurity, yes.
Yeah. Can this is a preventable disorder, and if yes, how, Dr. Vasundhara?
Ma'am, we can prevent this disease by identifying the risk factor for any particular patient which is coming to the OPD. There are certain risk factors given in the form of Gestosis score. We can calculate the score, and accordingly we can give aspirin to the patients who are at high risk of developing preeclampsia.
Okay.
So totally not preventable, but yes, we can identify and do.
Yeah. So it's like
start
you
her on
cannot
aspirin.
prevent it, but
Also,
you can
we
modify.
there are certain yes.
Yeah. Okay.
Also, there are certain tests which can be done for this. We can do an early uterine artery Doppler to see whether there is remodeling or not. Also, there are certain new tests available as predictors of preeclampsia. In that,
Okay. So how to identify these high risk cases?
ma'am, on the basis of the history, we can ask if she previously had a history of preeclampsia, if she is a known case of chronic hypertension, or if there is a family history of preeclampsia, or if the patient is having any diabetes or any renal disorder, if she is a known case of PCOS or an autoimmune disease like SLE or APLA, or if she is suffering from any thrombophilia.
Very correct. Then Madhuri, what could be the other ways in which we can pick up?
Yes, ma'am. Primary patients generally have more chances of having preeclampsia. So, in the history, we can know early pregnancies, teenage pregnancies, and more than 35 years age have more risk. And definitely family history and those with obesity can also present with preeclampsia.
Okay. Some pregnancy related condition which predisposes to this?
Multiple pregnancies, and then in case of vesicular mole, there can be preeclampsia.
Correct. IVF conception also. So this is what is known as, what we have compiled is known as Gestosis score. Yeah. So if you are putting these high risk factors, they have been assigned as grade 1, grade 2, score 1, score 2, and score 3. And if the score is coming more than 3, then the patient is high risk for the preeclampsia. And this score is so simple that it can even be done by ANM and midwiferys if they have been learned properly. It doesn't require much of the resources. So can be applied at periphery also. So this is what is the advantage of Gestosis score. Okay.
I would like to share, Nitika. I would like to share that shortly I'm going to launch a Gestosis app.
Okay. Okay.
And so all you have to do is just enter that, and at the end of it, you'll get the score. So I'm working on that with some software people. And actually, I wanted to release it in Gestosis conference, but it's taking some time. So it will be launched shortly, and all of you will be able to use it for every patient.
Looking forward for it, madam. Definitely.
Yeah.
Okay.
Yeah.
Preeti, can you take this? What are the other tests and markers that can be used in prediction? Is she here, Dr. Preeti?
Yes, ma'am. Yes. Hello, ma'am.
Yeah,
Yes,
yeah.
ma'am.
So the question is, what are the other tests and markers that can be used for prediction of preeclampsia?
Madam, first of all, BP, so that we will see uterine artery Doppler, early detection. If uterine artery Doppler, if PI is more than 2.5.
Biochemical markers I'm asking.
Yeah, sorry. Yes.
Yeah.
So, madam, in that PA, PPA, that we will see, placental growth factor.
Very correct.
And vascular endothelial growth factor also.
So these are all decreasing if you are getting a high risk.
These are decreasing, and increase beta HCG levels and fibronectin levels.
Very correct. Very correct. And even if you are seeing a mean arterial pressure, this is so
more
simple.
Than 85, more than 85.
And her basic blood pressure, if it is more than 130/80 before 20 weeks, that also gives one idea, right?
Yes.
Okay. And can you elaborate this triage placental growth factor test? Have you heard about it?
So, placental growth factor, if it is test positive, highly okay. If it is less than 12 pg per ml, then test positive, highly abnormal, and interpretation will be severe placental dysfunction and increased risk of preterm delivery and preeclampsia. Then if it is more than 12 pg per ml, then it is considered as abnormal, placental dysfunction and increased risk of preterm delivery with preeclampsia. Then if PIGF is more than 100 per ml, test is considered as negative, that is considered as normal, and no placental dysfunction are unlikely to develop preeclampsia, and delivery within 14 days of the test.
Yeah. So we have these markers and we can use them if we require certain cases who are affordable, and if we can do it, and these are the things that we can use for prediction, right? What is the role of, as you were speaking of uterine artery Doppler, so now tell me, what is the role of uterine artery Doppler?
Evaluation time is first trimester, madam. The goal is to identify high risk woman, and it is done at 11 to 14 weeks of pregnancy. And it is better if it is coming as more than 2.5. So then we can start with the ecosprin, and that is with 150 dose HS. And in few cases, if it is going more than 2.5 or near about 3, then we can consider to start with LMWH also. And then in second trimester, 19, if it is done in between 19 to 24 weeks, and abnormal findings like high PIRI or persistent diastolic notching are strongly associated with adverse outcome. And then third trimester, monitoring helps in assessing the late onset preeclampsia and FGR.
Very correct. Very correct. Yeah. What is which is the test that is having the best predictive value? Dr. Pooja? I think she joined. Yeah.
Yes, ma'am, I joined, but I was lost, so I don't know what
So I'm repeating the question. We are discussing about the prediction of PIH. So can you have one best predictive test that you can say for prediction of PIH?
In the first trimester, we do uterine artery Doppler, and that PI, if it is raised, so it gives prediction that the patient may have hypertensive disorder or the baby may go in for a fetal growth restriction.
Okay. So there is no single test which can predict the PIH accurately and promptly. It's a combination test. And if we can apply these combination, we can do wonder with the patient in predicting them. So one of them is the FMF triple test. It is done in first trimester, and this is the screening method for early detection. Here we combine maternal history, mean arterial pressure, uterine artery PI, and again placental growth factor. The time is in between 11 to 13 plus 6 weeks, and the detection is so wonderful. It is 90% and the prediction is 75%. And besides this, I just want to draw the attention of all of you on this test. See, if you see, these are the different screening tests which are available till now. An N number of research has been done on all of these tests. But if you see the statistics singly, the false positive rate is similar, 5 to 10% for all. If you see the detection rate of preeclampsia in less than 34 weeks, if you are applying single test, the detection rate is somewhere around 50 to 60%. See the wonder, if you are using two tests, the detection rate goes to 80 to 90. And the two tests are mean arterial pressure and uterine artery PI. If you're combining all of them, then the detection rate is somewhere 93 to 96. So this is what is the wonder, that it's it's not a single test domain. It's a combination of all these tests that we can use and can detect the high risk patients and produce the prevention. Now, if you see the early onset preeclampsia, these are the tests which are best. That is mean arterial pressure, uterine artery PI, PAP-A, and placental growth factor. But if you are speaking about late onset preeclampsia, it is the S-split is to placental growth factor ratio that gives you better prediction. Now, my question is, can we give preventive therapy, and what are the evidences for it? Pooja, you only answer it.
Preventive therapy is ecosprin. We usually now start ecosprin as soon as we see there is any risk factor for hypertension or previous, if the patient had previous history of PIH, we at the first visit we start ecosprin. Can be low dose also, 75 milligram daily. And
see what evidence is.
These may help the patient prevent, help the patient to prevent hypertension.
Yeah. So proven therapies are only two. That is, one is calcium, more than 1 gram. And second is 150 milligram daily, not 75. If you have to have an effect, then you have to start 150 milligram. There are different trials running for low dose. We'll not discuss in this platform those trials, but what is being proven till now is 150 to be started at window of 11 to 14 weeks and up till 36 weeks, nothing less than that. This is the ASPRE trial of 2017, which has encountered 1800 patients which were high risk. And what was their result is they reduced the early onset preeclampsia in 82% and late onset preeclampsia in around 62%. So it has proven its efficacy beyond any doubt. So just do not miss this. That is ecosprin 150 in 11 to 14 weeks. And the second is calcium, more than 1 gram per day is to be given. Rest all these therapies are placebo. Low molecular weight heparin, multivitamin, magnesium, vitamin C, antioxidants, all restriction, bed rest, nothing works. These are the only two things that you have to remember and you have to implement in your patient. I think we have done justice with the time as well as with the topic. Thank you very much, all the learned panelists, for putting your efforts in this. And thank you, Dr. Manisha, for bearing with us.
Thank you, ma'am. It was such an interesting panel to hear from you.
Thank you very much. Thank you.
Thank you, ma'am, for the opportunity.
Yeah. Sheila, madam, is she here?
Yes, she is here. I think so. Yeah. So let me.
Yeah. Here only. So very nice slides and very nice discussion. And I'm so happy to know all of you, your credentials, your CV. So nice to see you. Manisha, all of you are doing a great work, okay? And all of you are great academicians. Good. I will share those, keep this group alive. I will share all the guidelines. And one more thing I wanted to tell you is, through ICOG, I'm going to start a past registry. Placenta accreta spectrum. I'm waiting for the, the username, and then I would like all of you to spread the news so that we collect the cases, for what reason we are getting more cases, and let us have, because we are in ICOG, we should do some research. So that is another thing, HDP guidelines I will share. I must share with you, today I had a case of pulmonary edema, in an institute. And then everybody said, no, madam, I don't think it is there. An elderly patient, 42, BP is just 140/90, but she has come where there are lung signs are there. Urine albumin is 2+. She has not followed any treatment. I did POCUS, Dr. Suchi. Okay,
great, ma'am.
I did POCUS, point of care ultrasound. I did. You can just use a convex probe. You have to keep it as your what do you call it, as a phrenic angle. Suddenly I will not remember the name now. Costophrenic angle on both the sides. And I got B lines.
Okay, great.
So we detected pulmonary edema early. So point of care test, that is the ultrasound, lung ultrasound. You can use the same convex probe, keep it at the costophrenic angle, and you will find those lines. You can go on Google or you can search, you will find it. But it is a very, very useful investigation. And immediately, we did not wait for anything. I mean, NTG drip was started and she was taken up for section. So NTG is a drug of choice whenever there is a pulmonary edema. Okay. And NIV. I must tell you, because the case which I told you, I don't know, I'm scared of pulmonary edema now. Last week we had one severe pulmonary edema. We couldn't save her, but I had to do a perimortem section. The baby is doing good. Okay. Baby, but we couldn't save. I mean, couldn't save the mother. So labor room only we did the perimortem cesarean, and then breaking the bad news and counseling the relatives. You know how tough it is. Okay.
Right.
So what I'm trying to tell you is to diagnose pulmonary edema, oxygen saturation, respiratory rate, and you can also do focus. It is not difficult. I did it for the first time because I had attended the workshops and seen the intensive is doing. I did it and I could make out that it is there. So that message I wanted to give. Thank you.
Great.
Ma'am, it's been a wonderful experience. I mean, interacting with you has always been very knowledgeable for us, and we would like to be a part of your proceedings in the future, ma'am. So we enjoyed being a part
Yeah,
of
yeah.
this
I'm going to
program.
share everything, all of you.
Yes, ma'am.
HDP survey is also there. That will also come. Okay. Good.
Yeah.
Thank you.
Thank you, ma'am.
Thank you very much, madam.
Thank you.
Nitika
Thank you
ma'am,
so
this was
much.
a great panel.
So,
Yeah.
Thank you,
you.
madam. Thank you.
Yeah.
Thank you, all the panelists. Thank you, Pranjal. And
Yeah.
thank you, Manisha. Okay.
Let me
Thank you
propose
so much,
of
ma'am,
thanks,
for
ma'am.
giving the
Just
opportunity.
take
माझी
one
अजून माझी ताडोबाची ट्रिप बाकी आहे.
Yes, ma'am. बस माझ्यावर आहे. तुम्ही सांगा कधी येता ICOG चे
Manisha ma'am will call us again now.
and we'll go forward.
आपण सगळ्यांनी जायचं. आज जेवढे लोक आहेत तेवढे सगळे जाऊ.
Yes, all are welcome. All are welcome.
But anyway,
Pranjal is
all of
calling
us
us
we
from
will
Amravati
meet
now.
in.
Yes.
Yeah, we'll meet in Amravati and then all of you come to Bangalore.
Yeah.
All of you come to Bangalore for ICOG conference in August 21st, 22nd, 23rd. Okay?
Sure, ma'am.
Yeah. And those who are eligible to apply for FICOG, please apply. We also have a convocation. I'll share all the details in this group.
Okay.
Because I can see most of you are from institutes. Okay? Yeah. Thank you.
Thank you, ma'am.
Thank you, ma'am.
So with this, I propose my vote of thanks. Please bear with me for again for 2 minutes. Yeah.
Yes, ma'am.
First of all, I would like to extend my thankful gratitude to our respected ICOG chair, Dr. Sheila Mane madam, and Dr. Sneha Bhuyar madam for giving me this opportunity for conducting such an extensive, informative webinar. Today, we have Galaxy of Stars Academic in this webinar. Dr. Respected Zungare madam and Dr. Suchi Jain madam. Yes, for their excellent informative talk, I would like to extend my thankfulness because uh, hearing from you both has always been a treat for me, and most of us here have enjoyed your talk. Again, then we had an extensive panel under Dr. Nitika Rughavanshi madam with an again star galaxy of all the panelists, the learned panelists, and so much of you have contributed in this discussion. I am really thankful, Dr. Nitika madam, Dr. Madhuri, Dr. Vasundhara, Dr. Pooja, Dr. again Madhuri, Dr. Preeti, Dr. Mavish, Dr. Pranita, and Dr. Saili for their contribution in this panel discussion. And not the least, all the chairperson, Dr. Prerna Jain, Dr. Suchi Agrawal, Dr. Meera Dange, Dr. Lalita Lokhande, Dr. Rashmi Kahar for their extensive pearls of wisdom. Again, not to say that Dr. Amey Purandare has joined for his words of wisdom. So I thank him also. With this, I conclude that this session is over. And thank you all for coming and joining and spreading the knowledge. Thank you. Thank you.
Thank you,
Yes.
Manisha ma'am. Thank you, Dr. Pranjal. Yeah.
Always
Been a
nice
pleasure.
to talk with you, Dr. Suchi, madam. Yeah.
I know we met long back.
Yes.
So
It's
nice
Thank
to
you.
see you again. Yeah.
Yes,
Thank you.
madam, please do one program in Chandrapur and we all will join here in Chandrapur. Yeah.
Yes.
Please.
No, you do CME, ICOG CME.
Okay. Yes,
Monisha,
ma'am.
you send a
Yes.
mail for ICOG CME.
Okay, ma'am.
Okay.
Yes, I will ask our president, Dr. Shalaka, to send one mail for ICOG CME. Yes, ma'am. Surely
Yeah.
we'll do that. Yes, thank you. Thank you so much.
Thank you.
Okay.
Bye. Bye.
And thanks to Sneha, Pranjal. I think both of them are not there. Pranjal, are you there?
Yeah, she has left. Emergency.
Thank you, Sheila ma'am,
Okay, then.
for
Bye.
giving the opportunity.
Thank you all. Yeah, thank
Thank
you.
you, ma'am. Thank
Thank you,
you.
Saili.
All of you from Amaravati.
Yeah,
Waiting
Saili,
see
nice
all
to
of
see you.
Amaravati.
Sure. Okay.
Bye.